A very good morning, everyone. I, Dr. Sheetal Samel, on behalf of ISA Nagpur City Branch, would like to extend my warmest welcome on this Sunday morning. Thanks to all the respected senior members and all my dear colleagues for joining us today for the CME on a very important and relevant topic, current trends in onco-anesthesia. As we know, cancer is a leading health problem worldwide. And according to the epidemiological data, approximately 40% of the people have a chance to develop cancer during their lifetime. As per the ICMR latest reports, there is a 12.5% sharp rise in the number of cancer cases in the past 5 years. We as anesthesiologists encounter cancer patients more than ever. And the cancer patient present with myriad of presentations, and with that comes along multitude of challenges, right from securing the airway, interactions of chemotherapy, drugs, radiotherapy, its side effects, the morbid surgeries, ranging from diagnostic to palliative surgeries, debulking surgeries, also palliative care and cancer pain management. Therefore, it becomes imperative that we are constantly updated about the current trends in management of such patients. I would like to request Dr. Kiran Vyabhare, President ISA Nagpur City Branch, to welcome the faculties, the speakers for today's CME, and all the respected attendees of today's program, and formally inaugurate today's program.
Thank you, Sheetal. Honorable Vice President of ISA National and Advisory Board Member, MSCISA, Dr. Anjali Bure, Madam, GC Member, MSCISA, and immediate past President, Dr. Saurabh Burde, GC Member, MSCISA, Dr. Sheetal Dalal, today's MMC Observer, respected Dr. Narendra Tamne, Sir, Program Head, Dr. Himanshu Marathe, Chairperson, Dr. Chandrasekhar Chand, Sir, Dr. Vivek Bhargav, Sir, today's faculty, respected Dr. Sushma Bhatnagar, Madam, Dr. Vijaya Patil, Ma'am, Dr. Sheila Mehta, Ma'am, Dr. Dipika Patel, all dignitaries who have joined online, seniors, teachers, and my dear friends. A very good morning and a warm welcome to the CME on the current trends in onco-anaesthesia. Anesthesia specialty is growing leaps and bounds and is branching into many subspecialties. Cancer is one of the leading causes of mortality globally. Around 60 to 80% of the cancer patients will require surgery. Advances in anesthesia will greatly improve the surgical outcome. Anesthetic strategies could have significant oncological sequelae. Avoiding some anesthetic medications can decrease the cancer recurrence. So, in order to keep ourselves updated, the ISA NCB has invited eminent faculty from all over India. So, let us hear from our experts. Without wasting much time, I welcome you all once again to the CAD and hand over the proceedings to Dr. Sheetal Samel. Thank you.
Thank you very much, ma'am. The program head for today's program is Dr. Himanshu Marathe. He's a consultant anesthesiologist in National Cancer Institute, Jamta, Nagpur. Dr. Himanshu, over to you.
Good morning, all respected faculties, members of organizing committee, all the delegates, seniors, friends and colleagues. If we look at the current trends for past a decade, globally cancer cases have increased by 21% and deaths due to cancer by 26%. Cancer cases in India have increased at an average annual rate of 1 to 2%. A World Health Organization predicts a 22 million annual new cancer diagnosed cases globally by 2030. There are various causes to these trends, such as global warming because of pollution, change in lifestyle, etc. But one important aspect is awareness among people and more and early detection because of availability of diagnostic modalities compared to earlier times. Out of all the diagnosed onco patients, as Madam said, 60 to 80% of them will require surgery for various intents like diagnostic, curative, or palliative. So to cater to such a huge burden, an anesthesiologist is required to have knowledge about the disease pathology and treatment modalities. Study of perioperative management by an anesthesiologist will help facilitate early return to intended oncological treatment, reduce length of hospital stay, provide multimodal and interdisciplinary analgesia, integrate supportive care, and improved oncological outcomes. The challenges faced during onco-surgeries are usually less talked about. So we decided to have a CME on this topic in an attempt to collectively enhance our knowledge and skills in managing onco cases. I hope we all will gain and have some take-home messages from this CME. I know all of you have joined the link to hear from the stalwarts of Onco-Anaesthesia fraternity. So without wasting much time, I would like to request Sheetal ma'am to continue with our sessions.
Thank you, Dr. Himanshu. I once again extend a floral welcome to all the chairpersons and faculties of today's program. Let me introduce you first with the chairpersons of today's CME. Our first chairperson is Dr. Vivek Bhargav. Dr. Vivek Bhargav is heading the Department of Anesthesiology at National Cancer Institute. He is the alumni of GMC Nagpur, and he is one of our senior and very experienced anesthesiologists from our Nagpur city. Our next chairperson is Dr. Chandrasekharan Cham. And as we all know, he's been a very active member of ISA, and he has served as past president of ISA Nagpur City branch. He was also a president West Zone ISA in 2018-19. Thank you very much, sir, for your presence. So with that, we'll start our scientific session. Our first speaker is Dr. Vijaya Patil, Professor and Head, Division of Clinical Anesthesia, Department of Anesthesia, Critical Care and Pain, Tata Memorial Hospital, Parel, Mumbai. She'll be presenting a talk on pre-operative workup for onco-surgery patients. The session will be followed by question answer sessions after the talk is over.
Good morning, everybody. In this brief talk about preoperative workup for oncosurgery patients, I will cover how we should preoperatively do the assessment for oncosurgery. For non-oncological patients, sometimes if we find that the patient is not fit, we can wait for 4 weeks, 5 weeks, we can optimize the patient and we can take the patient for the surgery. However, in oncological patients, that type of freedom we do not have. Surgery is very rarely elective. It's often urgent. You have got a brief time period, and sometimes it can also be emergent. The previous cancer therapies may cause or exacerbate the medical comorbidities, but delaying the surgery is not again an option to us because otherwise the cancer will progress and metastasize. Preoperative evaluation and management of comorbidities must take into account the impact of the cancer. For example, patients who have got large intra-abdominal cancer, they will be nutritionally depleted. Or some patients who have got huge tumors, they may be having underlying fever or subclinical sepsis. But the treatment, we cannot optimize them unless we take care of the cancer or tumor per se. Effective communication between all members of surgical, medical oncology, medical and anesthesia team is necessary because everyone is a team player whose treatment can affect the patient's outcome. The literature lacks definitive evidence-based guidelines regarding many aspects of preoperative evaluation of these patients, and most of the aspects we take from the non-oncological surgeries and some based on our experience and practice. Now, history taking, as you know, is the pillar of preoperative evaluation, and that's true for cancer patients as well. Extensive investigations are no substitute for proper history taking and clinical examination. And the basic principles are assume nothing, whether the patient is literate, patient is from high profile thing, assume nothing, and always seek primary source documents. Ask patients to get all medications physically, because many times we have found in our practice that what patient tells that he is taking and actually patient is taking, there is a big difference. Assess the patient functional status, because we generally for all the patients in preoperative examination, we take functional status assessment as a marker of cardiorespiratory reserve. But remember, in cancer patients, because of cancer per se, the impact on nutrition and the impact of previous chemotherapy, it can lead to muscle deconditioning, and that can be the cause for the patient's limitation on the functional status. And the detailed history of previous treatment, that's chemotherapy and radiotherapy, is extremely important. What about cardiovascular evaluation? The assessment is same as per the AHA guidelines of cardiological patients for non-cardiological surgeries. Other than that, many chemotherapy agents are cardiotoxic. Now we know practically everyone knows about adriamycin or doxorubicin, which leads to cardiomyopathy. But remember, the anthracycline class includes many more drugs, and we should be aware of all those drugs and their impact on heart. And there are many newer chemo agents like monoclonal antibodies or TKIs who do have effect on the cardiovascular system. So it's extremely important for us to know the newer chemotherapy agents and the effect on the cardiovascular system. Now, in anthracycline drugs, there are lots of agents like doxorubicin, daunorubicin, epirubicin, idarubicin, metoxantrone, and valrubicin. And there are taxanes, that paclitaxel, cyclophosphamide, and trastuzumab are the drugs which majorly impact on the heart. Now, when we talk about the effect of chemotherapy agent on heart, there are basically two types of effects that can happen. One is what anthracycline leads to. So, the anthracycline chemotherapy agent lead to cellular death, and it damages the heart with the first administration. This effect on the heart is cumulative dose related. So, higher is the dose, more is the effect. And because it leads to cellular death, the damage is permanent. The effect on the contractility doesn't recover. And the risk factors for these patients is if the patient is also receiving concurrent or had received prior radiotherapy in the mediastinal region, in the combination chemotherapy, if there are other drugs which also do have effect on the heart, elderly patients, if the patient has got pre-existing cardiac disease, and the hypertensive patients are more susceptible for the cardiac effects of anthracyclines. Now, drugs like trastuzumab lead to cellular dysfunction, and because of that, they are predominantly reversible. So after the chemotherapy is stopped, over the period of the time, the heart function comes back to normal. And for the risk factors for this is prior or concurrent anthracyclines, paclitaxel along with it, elderly patients, previous cardiac disease, and the obese patients are more prone for the trastuzumab related cardiac injury. What's the incidence of cardiac dysfunction with these drugs? So as you can see in anthracycline, it is dose dependent. So if the dose is less than 400 milligram per meter square, the incidence is 3 to 5%. But as the dose increases, the incidence also increases. And the newer anthracyclines like methozantrone or liposomal anthracyclines, they have got the least effect on the heart. The alkylating agents like cyclophosphamide and ifosfamide also lead to cardiac toxicity. The newer drugs, as I told you, taxane, that's paclitaxel and docetaxel, they also affect the heart. Paclitaxel has less than 1% incidence. Monoclonal antibodies, as I said, trastuzumab, bevacizumab, they generally give rise to the reversible cardiac depression. So over the period of the time, the contractility improves. And small TKIs like sunitinib and sorafenib, these drugs also affect the cardiotoxicity. So we should know what the regimen patient has taken, how much dose patient has taken, and how much time has lapsed between taking the chemotherapy and patient coming to us. Now, should we subject all patients to routine 2D echo after anthracycline? If you get a patient on table who doesn't have 2D echo, do you need to postpone that case? So this was a retrospective audit where we looked at 788 patients over the period of 2 years. And you can see that dose of doxorubicin was 240 milligram per meter square. Now, because everyone is aware of the dose-dependent toxicity of anthracyclines, generally the dose is limited below 400 milligrams per meter square. And in this, you can see was defined cardiomyopathy as ejection fraction drop in 10% or more related to the pre-chemotherapy. We had only 0.8% of the patients who are asymptomatic with drop in the cardiac function. So you can take a call based on the patient's chemotherapy regimen, patient's functional status, and whether the patient has received any other concurrent chemotherapy agent. Other than cardiotoxicity in terms of decreasing the myocardial function, some agents also increase the risk of coronary artery disease, and that's mainly because of endothelial injury and procoagulant state. The worst in this is fluoropyridines, that's 5-FU, capecitabine and gemcitabine, which lead to almost 18% manifestation of patients manifest with myocardial ischemia. Vascular endothelial growth factor inhibitors and cisplatinum. Now, cisplatinum has got 20-year risk of up to 8%. So someone who's received cisplatinum coming to the surgery after 10 or 15 years, a non-malignant surgery, just keep it in mind that these patients also can have the underlying coronary artery disease. Now, some agents also lead to QT prolongation, but these agents, if you look at average QT prolongation in the agents, it's borderline. It really does not lead to increased risk of torsades, except AT or arsenic trioxide. Now, this agent is used in APML, that is acute promyelocytic leukemia. So that's a hematological malignancy. These patients do not come for any surgery per se, but they may come to you for emergency surgery. And the effect of arsenic trioxide on QT prolongation is temporary. So it's the drug is given, it may last for a short period of the time over the period. So generally, when the patient is due for next dose, the QT comes back to normal. So if these patients come for emergency surgery, surgery, just keep it in mind. You need to know when the patient has received ATO last and what is the duration. And in these patients, then you can also look at whether the patient has got other risk factors. Like, and as we know that electrolyte imbalance because of any reason is the major risk factor for additional causing prolonged QT. And there are certain drugs. So these patients, again, if at all you get them for emergency surgeries, then you look if the patient is on any other drug which can lead to QT prolongation, and you can stop the drug, and you can look at patient's QT and electrolytes. The vascular endothelial growth factors also inhibitors many times also lead to hypertension. And as you can see that axitinib and vandatinib have got the highest incidence of all grades of hypertension, but the bevacizumab, sunitinib and sorafenib also lead to the hypertension. So these patients, evaluate them properly, in the ward, or ask the patient to keep the blood pressure chart, and these patients may require the optimization of their blood pressure. The cancer chemotherapy agent also affects autonomic nervous system and can lead to autonomic dysfunction. And all of us are aware the patients who have got autonomic dysfunction really sometimes give us hell of a time during the perioperative period because of very labile hypotension or the blood pressure changes. And these patients are very prone to get postural hypotension, which can have implications if we are planning to give central neuraxial blockade or mobilization of the patient in the perioperative period. So these patients generally have the maladaptive orthostatic response and aberrant blood pressure variability. The common culprits who give rise to autonomic dysfunction are vincristine, doxorubicin, cisplatinum, vinblistine, and bleomycin, which is used in germ cell tumors. And these patients it's a solid tumor, so they'll always present for the surgery. And patients who have received the paclitaxel. So if the patient has received any of these chemotherapy drugs containing chemotherapy regime, please evaluate these patients properly from the point of view of ruling out or ruling in autonomic dysfunction. Though there is no treatment for it per se, but then obviously you can take more care and decide about your anesthesia plan. The other treatment that these cancer patients get is radiation, and generally other part radiation is not a problem, but if the patient has received radiation to the mediastinum, then it does affect the heart also, and sometimes the lungs, and this can give rise to additional problems. So high dose radiation exposure to the thorax is used in patients undergoing breast conservative therapy for CA breast or MRL, especially on the left side, lung and esophageal cancer, and as a complement to systemic treatment in lymphoma. So most often these changes become clinically apparent many years later, and so this is important in patients who are cancer survivors coming for the other surgery later on in life. And this study has shown that the risk of RIHD in cancer survivors is almost, you can see, is more than 6.3% in Hodgkin's and 2 to 6% in breast cancer. And these patients have got, especially the Hodgkin's, they can lead to sudden cardiac deaths. And the risk factors, as I told you, is anterior or left chest irradiation, high cumulative dose for irradiation, more than 30 gray. Younger patients, high dose of radiation fraction that is more than 2 gray per day. So you have to look at what is the schedule of these patients for the radiation. Presence and extent of tumor in or next to the heart, lack of shielding, concomitant chemotherapy, especially the cardiotoxic drugs like anthracyclines, cardiac risk factors if the patient is already existing, and pre-existing cardiovascular disease. So what is the RIHD? What form of, how does it affect the heart? It's basically because of the chronic pericarditis. So radiation acts like sort of a burn, so it heals by fibrosis, and that can lead to chronic cardiac constriction and chronic pericardial effusion. And it is observed in up to 20% in patients within 2 years following irradiation, which can then lead to constrictive pericarditis, which is dose dependent. It can also affect the valve, and again that valve affection will get manifested later in life. So the incidence of significant valve disease is 1% at 10 years, 5% at 15 years, and 6% at 20 years after radiation exposure. And it can be ranging from mild AR to severe AR to AS, or mild MR or mild PR. As cancer is sort of majorly the disease of elderly people, these patients will have underlying coronary artery disease, which during our preoperative evaluation we will find out. So if the patients have got coronary insufficiency, like patients who are coming from non-malignancy surgery, since we have got time, the patients can get properly evaluated and managed and then come for surgery. But however, over here, since we do not have much time, so we have to decide about the risk-benefit ratio between coronary revascularization and delaying the surgery versus surgery with medical management. And that's the reason we need good communication between surgeons and cardiologists. So if the surgery is really early, like it's sort of urgent that you have to do, then you can talk to the cardiologist. And if the patient has really got significant coronary artery disease, the patient can undergo balloon angioplasty or CABG, where you require dual antiplatelet agent only for 2 weeks, and after that the risk of coronary thrombosis decreases significantly. However, if someone puts a drug-eluting stent, that that there's minimum 3 months that patient needs dual antiplatelet therapy, and during this time operating on the patient can be a problem. This radiation effect to the carotid region generally is not in the acute stages, but the patients, again, as I told you, the chronic patients, cancer survivors coming for the surgery later in life, you have to be aware of this if the patient has received radiation in carotid region. And this is commonly given in patients who have got squamous cell carcinoma of the head and neck, that is nasopharyngeal carcinoma and oral malignancies. Patients with CA breast, if they have got supraclavicular mets and all, they can get in that region. Lymphoma patients as part of whole body irradiation, and pituitary adenoma. What happens when the radiation happens in the carotid region? It typically gives us something called as radiation vasculopathy, and that is chronic occlusive cerebrovascular disease which will affect the medium and large diameter arteries. And the form is basically like accelerated form of atherosclerosis, and that's because the radiation affects the vasa vasorum, which will then affect the vascularity of your media and intima, and which can lead to the damage and then healing with the fibrosis and scarring. These lesions are more extensive, involving longer segments and atypical areas of carotid segments. And as I told you, the time interval from the development of significant carotid artery disease is 5 to 10 years. So those patients who have survived cancer and coming later in life, you have to keep it in mind. And this meta-analysis showed that the radiation to the carotid region increases the relative risk of developing stroke from 1.5 to 10. So that is the risk that the patient can have for the stroke or TI related thing. So patients coming with that history where they have got radiation in the neck region, take the proper detailed history to rule out cerebrovascular insufficiency, auscultate in the carotid region for the carotid bruit. If there is any significant stenosis, you will get that, and advise the carotid Doppler studies, which will help you in knowing what is the status of the carotids. Getting the respiratory system pulmonary function test as for non-oncological surgeries, the PFTs are rarely helpful in the perioperative period for patients undergoing non-lung resection surgeries. For the patients undergoing lung resection surgery, you have to do the PFTs to know how much portion of the lung can come out safely, which will not make patient respiratory cripple. The bleomycin leads to pulmonary toxicity, which is in the form of interstitial pneumonitis in acute stage, which later on progresses to fibrosis. So these patients have got pulmonary toxicity up to 10%, and methotrexate also can give up to 8% incidence of pulmonary toxicity, rarely seen with other agents like cyclophosphamide, gemcitabine, oxyplotine, or busulfan. And in these patients, because it leads to fibrosis, the interstitial fibrosis, just get the DLCO done, which will tell you what is the patient's alveolo-capillary membrane situation. Many of the chemotherapy agents also affect renal function, and the effect on kidney of chemotherapeutic agents, it's various types based on what chemo. Like agents like bevacizumab and gemcitabine give rise to renal thrombotic microangiopathy. Methotrexate gives rise to crystal nephropathy. Cisplatin and ifosfamide give rise to ATN. Cisplatin carboplatin also leads to magnesium wasting. So if patient has received any of these agents, then get the RFTs done. Preferably get the GFR done, which will give you a good idea about how much is the drop in GFR, and get the serum magnesium done, because many of these patients may have the magnesium wasting. Now, nutritional assessment, there is no gold standard, but as we know, there's something called as cancer cachexia. Many of these cancer patients will be nutritionally depleted. And in some patients, there may be problem with the intake because of the position of the tumor, like head and neck cancers or patients with stomach cancers. So in those patients, when possible, get the supplemental feeding using nasogastric tube or nasojejunal tube. Hyponatremia in the form of SIDH is frequently seen as a paraneoplastic process. But in our experience, what we have seen is patients who are mildly hyponatremic, where sodium is between 130 and 135. And if the patients are stable, you really don't require any intervention. It doesn't affect the perioperative outcome. What I'm talking about is mild hyponatremia. In physical examination, it's typical like what you will do for any other major surgeries. Just look at patient's effort tolerance. You can use 6-minute walk test or stair climbing test or shuttle walk test. to know what is the patient's if a tolerance that will give you, what is a cardiorespiratory reserve. But as I told you in the beginning, just think of the factor of muscle deconditioning. Patients coming for head and neck cancer, evaluate their airway properly. I think the next talk is on that. So I'm not going to go into detail, but look at the patient where the tumor is involving, whether it's invading base of the tongue, crossing the midline, whether there are large lymph nodes in the neck which can affect your mask ventilation or the front of neck axis. And look at the recent imaging of CT and MRI to know what is the status of your central airways. These patients many times will be in pain and anxiety. The incidence of anxiety and depression in cancer patient is 20 to 40%. So evaluate patient from that point of view. You can refer the patient to a psychologist, counsel the patients, and many of these patients may be receiving analgesic. So you need to get the detailed history of what analgesia they are receiving, whether they are receiving opioids, because again, that will decide what is the perioperative pain management strategy for these patients. One more thing I would like to say is most of the cancer patients have got as their cancer metastatic workup will have a CT thorax. And every anesthetist should know about CT findings in airway and CT thorax. Now, this is what you can see that this patient, this is a heart, and you can see that this is something white. These are the calcified plaques, and these are coronaries. So this is called as coronary calcification. And severe coronary calcification has been shown to be a risk factor, or rather it's telling that there's underlying severe coronary artery disease. So ask your radiologist, or you can look at it and see if the patient has got significant coronary calcification. There are special programs where you can feed the data, and that tells you about the grading of the calcification. And in small study that we did, we found that severe coronary calcification is associated with underlying coronary artery disease and perioperative cardiac events. Also, you look for the patients because they are elderly patients. Many of them are cancer, as cancer is the major risk factor for many. Smoking is a major risk factor for many cancers. These patients will have underlying emphysema. Now, your X-ray chest is not a good sensitive thing to tell you about the emphysema. So you can look at the CT scan and you will know if the patient is emphysematous, bulle, and then you can again decide how you are going to manage the patient. Many of these patients, as we know that blood transfusion leads to increased incidence of recurrence because of immunomodulatory effect of blood transfusion, called as TRIM. So these patients, we will like to avoid or minimize the amount of blood that we give. And the only way we can do it is if we optimize the patient's preoperative hemoglobin. We know that the incidence of iron deficiency anemia is pretty high. And again, in these patients, because of the nutritional impact, it may be increased. So the incidence of iron deficiency anemia in one of the study in colorectal cancer was around 48%. So when these patients come to you, or rather you can talk to your surgeon and say that on the first presentation of the patient, if you know that this patient is going to go for the surgery, you get the iron studies done, and then appropriately you can either put patient on oral or IV iron therapy. There is not major advantage as far as the hemoglobin increment is concerned with IV and oral, but the only thing is that when you give oral therapy to the patient, you do not know about the compliance of the patients. When you give IV, you know that the patient has received that much of dose of iron. Along with that, you can give vitamin B12, and then you can and the present iron preparations that we are getting do not have any major reaction, so they are very safe to be given. So you can use these. Since for the major cancer surgeries, again, cardiopulmonary exercise testing, which looks at the integrated response of pulmonary, cardiovascular, hematological, and metabolic system. So here it's like doing a treadmill test along with a metabolic cart, which tells you about the patient's oxygen consumption and the anaerobic threshold. And again, there are no studies per se in cancer patient looking at the outcome. The majorly being studied in the major intra-abdominal surgeries, but now many of the studies I know are on the way in cancer patient, whether it can help us in prognosticating the patient. The last but not the least is we know that the cancer patient is not only between surgeon and anesthetist. There are oncologists involved, radiation oncologists involved. You need to get the chest physicians in, the physiotherapists and nutritionists are important part of management. So especially if you have got a cancer therapy center where you are majorly dealing with cancer patients and patients are coming for major surgeries, have something called as a joint clinic. So anesthetists should interact with all these specialists and to know how the patient can be managed optimally in the perioperative period and thus improve the outcome. So to conclude, oncosurgery is generally semi-urgent. Just because these patients have cancer or received chemotherapy does not mean they need battery of investigations. You can do targeted investigation based on history and physical examination. Preoperative iron therapy, iron study should be integral part of these patients. Know your newer chemotherapy agent well, so be in touch with the medical oncologist to know the impact of these drugs on the various organ systems. And multidisciplinary management to optimize is the key factor. Thank you.
A very good morning to all of you. Dr. Patil is not online right now, but she has very nicely pointed out multiple chemotherapy drugs which have effect on the cardiovascular system, the myocardial performance, and even the pulmonary tract. So utmost care must be taken, not during the initial part, but even in the long run. The cancer chemotherapy agents, they have a very effect on the autonomic nervous system. So regional anesthesia could be very disastrous in such cases in some patients. She has very nicely touched upon the optimal use of blood transfusions, even the nutritional support. Thank you, Vijaya madam, for your lucid and wonderful talk. I hand over the mic to Sheila.
Thank you, sir. Moving on to our next lecture for today, Anesthesia Concerns in Microvascular and Reconstructive Flap Surgery. Dr. Dipika Patel will be presenting this talk. Madam Dipika Patel is Associate in GCRI BJMC Ahmedabad. Her special areas of interest are airway management and onco-anaesthesia. Madam is also a proud recipient of PG DPM from Cardiff University, United Kingdom. She's also received Appreciation Award by Indian Resuscitation Council for excellent participation in COLS activity. She has 5 international and 5 national publications.
Very good morning to everyone. Today my topic is on anesthetic concerns in the microvascular reconstructive flap surgery. I'm Dr. Dipika Patel from Gujarat Cancer and Research Institute, Ahmedabad. This is my institute. Head and neck reconstructive surgery represents a major challenge facing the need to achieve good cosmetic and functional outcome. Free flap performed with microanastomosis is a good option in trying to achieve this goal. This technique is very complex, and despite improvement in the surgical skills, hypoperfusion and necrosis of transfer tissue represent major problems. As an anesthetist, how can we help? Anesthesia may be an important and determining factor for success of this technique due to its role in hemodynamic stability and regional blood flow. In head and neck cancer, because of extensive surgery, there is a big defect occur, and surgeons put microvascular flap. So there are 2 types of flap, pedicle flap and free flap. Pedicle flap released and twisted around the neurovascular pedicle, and thus without interruptions of blood flow. So pectoralis major myocutaneous flap is for head and neck cancer surgery, and latissimus dorsi for breast reconstruction surgery. Free flap neurovascular pedicle is removed from the donor site and transplanted by microvascular anastomosis to a major location, to a new location. The transverse rectus abdomen is myocutaneous, free flap, and deep inferior epigastric perforator, free flap for breast reconstruction. Ulnar artery foramen and radial artery foramen, free flap, and free fibular flap for head and neck surgeries. This is the free fibular flap. Fibular flap after surgery, and this is a scapular flap. So how surgeons perform this technique? First off, harvest the flap and clamp the vessels. Primary ischemia occur as soon as the blood flow stops. After that, reperfusion as soon as the arterial and venous anastomosis are complete, and after declamping. So between these 2 steps, there may be a 60 to 90 minutes, not more than that. Secondary ischemia is a result of flap perfusion, and anesthetists play a good major role in this stage to prevent the secondary ischemia. Blood flow in pedicle and free flap works on Higgins and Pauchley's equation, and it is directly proportional to the pressure difference at the tube ends and radius of the vessel. So if vasodilatation occurs, then there is an increase in the blood flow, and it is inversely proportional to the viscosity. So if viscosity is increased more than 30%, around 40%, then blood flow will be decreased. Head and neck cancer patient are generally having malnutrition, and because of the cachexia, tumor cachexia, and anorexia because of the radiotherapy and chemotherapy, and muscular weakness because of the increased BMR. So malnutrition occurs in 35 to 60% of the patients with head and neck cancer, particularly those with the oropharyngeal and hypopharyngeal squamous cell carcinoma. Mortality rate of up to 30% have been associated with a 20% preoperative weight loss. Authors do analysis of risk factors associated with the microvascular free flap failure. And they do this study to determine the association of flap failure with the individual factors like age, gender, ethnicity, body mass index, intraoperative transfusion, diabetes, smoking, alcohol, ASA classification, year of operation, operative time, number of flaps, and type of reconstruction. And they concluded that overall incidence of flap failure was 4.4%, and operative time was identified as an independent risk factor for free flap failure. As an anesthetist, preoperative assessment is very much important. Patient Sheila is a well-known predictor of good outcome in the microsurgery. Head and neck cancer are generally having a habit of smoking, alcoholism. Therefore, lung and heart comorbidity will be there, and poor nutritional status. And surgical mortality will be increased if patient has diabetes, 5 times higher than other patients. And obesity is a risk factor for major complications if BMI is more than 30. Airway assessment is very important in head and neck cancer patients. Airway management may be complicated by obstructing lesion, preoperative radiation therapy, or revision surgery after failure of flap that has further distorted the patient's anatomy. So you have to check for mouth opening, restriction of neck and jaw movement, and obviously patency of nostril and size of the nostril. So in investigations, you will advise routine investigations, blood count, coagulation profile, renal function test, random blood glucose or fasting blood glucose, PPBS, if patient is diabetic, chest X-ray, ECG, if needed, echocardiography, pulmonary function test, blood gas analysis, cardiopulmonary exercise test, or others should be considered if the associated pathology justify that. All patients should be typed and have reserve of blood. How will you optimize this patient? So good dental health is very much needed to prevent post-radiation osteomyelitis resulting from the untreated dental caries. Enteral feeding before 7 to 10 days of surgery. Nasogastric feeding tube if patient is not taking orally. Preoperative albumin is low, then you have to transfuse albumin to prevent the complications. Stop smoking 6 to 8 hours prior to surgery, and preoperative fasting should be minimal. That is, clear liquid should be allowed up to 2 hours and liquid up to 6 hours before anesthesia. So the basic target of anesthesia is to provide adequate perfusion of transplanted tissue and minimize any morbidity associated with prolonged surgery and anesthesia, because this surgery is prolonged for 8 to 10 or maybe 12 hours long duration. And the basic requirement for microanastomosis flap are to ensure hypodynamic circulation and maintain thermia. Maintain normothermia. So will you go for intubation or tracheostomy? A patient having trismus and whose mass is there, then you have to go for awake fiber optic intubation. And if you have no fiber optic, then you can go for spontaneous under inhalation induction with spontaneous breathing. You can do blind nasal intubation. You can also do retrograde endotracheal intubation. Electric tracheostomy under local anesthesia is another option if patient has comorbidities and the surgeon insists if they are planning for post-operative tracheostomy, we can go for pre-operative tracheostomy. So active warming for induction, room temperature should be 24 to 25 degrees centigrade. Keep patient normothermic with active warming with warm fluid and warm blanket. Patient positions deserves meticulous attention, head up position, and take care of pressure points to prevent the damage to the peripheral nerves. Secure whiteboard IV cannulation. Location must be discussed with the surgeon to spare the harvesting place, and use of pneumatic compression stocking whenever possible. In maintenance, balance anesthesia, avoid nitrous oxide, control ventilation with normocapnia. And when surgeon using microscope, tidal volume should be low to minimize the movement. Control hypotension during dissection to decrease the blood loss. Head up position to improve the venous drainage or infiltration with local anesthetic drugs. When flap is reperfused, patient should be normothermic and well filled. Sympathetically blocked with high cardiac output. And regional block may be advised for harvesting the flap. So authors do a study for differences between the total intravenous anesthesia and inhalation anesthesia in free flap surgery for head and neck cancer, and preoperative hemodynamic data and postoperative medical complications were determined. And they concluded that there was no difference in the surgical complication rate, but patients in TIVA group developed fewer pulmonary complications as compared to inhalation group. Authors do study on microvascular changes during anesthesia under sevoflurane compared with the propofol. And they concluded that sevoflurane anesthesia less extravasation of fluid into the interstitial space and thereby decrease the edema and reduce the interoperative fluid requirement. So preferred anesthetic agent inhalation anesthetic agent is sevoflurane. You can also use diaspurine. Fluid therapy is very important in microvascular surgery. Ideal fluid used for plasma substitute in microvascular surgery should not pass freely through the damaged endothelium and must have half-life long enough to prevent postoperative hypovolemia. The goal of intravenous fluid therapy in microvascular surgery is to maintain intravascular fluid volume for optimal tissue blood flow and oxygen transport to all tissue, including transfer fluid tissue. So crystalloid for insensible fluid loss, synthetic colloids for replacement of plasmas, moderate hemodilution, high cardiac output, low peripheral vascular resistance, normal arterial blood pressure, that is systolic more than 100 mm of Hg, mean arterial pressure more than 70 and with large pulse pressure. And according to research literature, a goal-directed fluid therapy is needed. You can use the vitamin safely, and you should avoid diuretic. Blood transfusion decision must be balanced a patient's medical problem with the possibility of an increased cancer recurrence rate. Blood transfusion is recommended when hemoglobin falls below 7 to 8. Hematocrit 30 to 35% is an optimum balance between viscosity, blood flow, adequate oxygen carrying capacity. Now, does low-dose heparin have a significant role in free flap surgery? So in this study, patients in a low-dose heparin group had no significantly lower rate of flap failure compared with the no heparin group. So in coagulation and thrombolysis, subcutaneous administration of heparin is for improvement in the flap survival. Intravenous heparin shows no clinical benefit. Aspirin seems to be as effective as subcutaneous heparin. Clopidogrel, it reduces the microvascular thrombosis in rat, but not in the human study. Thrombolytic agent by surgeons used into thrombosed vessels, and intravenous heparin before flap harvesting. And vessel lumen is just irrigated with heparinized solution. So temperature monitoring, nasopharyngeal and rectal, difference between these two should not be higher than 2 degrees centigrade. Invasive arterial blood pressure monitoring, because this surgery is too lengthy. Urine output should be maintained 1 to 2 ml per kg, and should watch for anti-calcium also. Post-operative, will you extubate this patient or not? So for breast reconstruction surgery, you have to extubate this patient. And to reduce the coughing and the retching, you should have smooth emergence and extubation. You can change the endotracheal tube to laryngeal mask before reversal of neuromuscular blockage. You can give lignocaine 0.5 milligram per kg and a small titrated dose of beta blockers. In head and neck cancer surgery, you should keep the endotracheal tube overnight, and in the morning you have to extubate. Generally, we are doing this method, and we are giving intravenous tramadol 100 milligram and with antiemetic drug. Tramadol prevent post-op severing, and so obviously oxygen requirement. So it is a good option. Replacing tracheostomy tube with intubation to manage the airway in head and neck oncology patients. When compared with tracheostomy, overnight intubation resulted in a short mean stay in ICU, a shorter overall hospital stay, less time to first oral intake, and a lower rate of lower respiratory infection. So you should keep tube overnight, and in the morning you can extubate. Avoid NSAIDs in early stages. COX inhibitor and paracetamol can give tramadol. Regional anesthesia for breast reconstruction surgery, that is TAP block and erector spinae block. When you give opioids, you have to give antiemetics. And so this is the thumb rule for post-operative care, even intraoperative. Normothermia, hypodynamic circulation, high cardiac output, low systemic vascular resistance, normal systolic blood pressure, that is more than 100 mmHg, hematocrit 30%, urine output more than 1 ml per kg per hour, SpO2 more than 94%, with effective analgesia, and periodic monitoring of flap with the Doppler. Causes of flap failure. Flap failure can occur 4%, chances of 4%, and chances of re-exploration is around 10% within 24 hours. So how flap failure occur? Because of the arterial thrombosis and vasospasm, surgeons can give verapamil and papaverine, lignocaine to prevent vasospasm. Venous drainage, the venous thrombosis, vasospasm, mechanical compression because of dressing and positioning. Flap edema can occur because of excessive use of crystalloid and excessive hemodilution. Generalized vasoconstriction can occur because of the hypovolemia, hypothermia, pain, and respiratory alkalosis. Hypotension because of the hypovolemia and regional anesthesia can lead to flap failure, and even prolonged ischemia of flap can lead to flap failure. So if re-exploration is done within 6 hours of surgery, then chances of survival of flap will be 75%. Emergency re-exploration. You will end up in the disaster if you have no endotracheal tube. and no dystomy, and patient is having bleeding. So at that time, you have to go for emergency tracheostomy only. So it is advisable to keep tube overnight for this surgery. So in summary, anesthesia for microvascular flap surgery is a challenge. The role of anesthesiologists include the optimization of the physiological condition for flap survival without increasing non-surgical morbidity. Close communication and knowledge of the steps as well as the pathophysiology are necessary to ensure the favorable outcome. So this is the PMMC DP flap for extensive growth. It is extensive surgery. Patient is very much malnutrition, and this is the armored tube pre-operatively tracheostomy. And this is a gracilis free flap, the lip shape flap with post-op tracheostomy. Tongue reconstruction with radial artery forearm free flap. Cancer nose, radial artery forearm free flap. This is beautiful nose construction. Basal cell carcinoma, radial artery forearm free flap. Beautiful result. And again, this is a free fibular flap with the screw and plate. This is the result. And medial sural artery perforator flap for cancer buccal mucosa. So thank you very much. Thank you very much to Dr. Sarita Joglekar, Dr. Himanshu Marathi, President Dr. Kiran Vehware, Dr. Vivek Bhargav, HOD of National Cancer Institute, Jamtha, Nagpur, and Dr. Anjali Khole for giving me that opportunity. Thank you. Thank you very much.
Thank you, Dipika, madam. A very nice talk. As you know, there are many factors for the success and failure of microvascular flap, and you nicely mentioned about the anesthesiology part for the success of microvascular flap. So, is there any question in chat box? Himanshu, please ask the question.
I have a question.
Hello, ma'am. Hello. Hello, Dr. Dipika, ma'am.
Hello.
Yeah. Ma'am, there is one question. You talked about use of dobutamine intraoperatively to maintain the MAPS. So, is there any specific contraindication for use of noradrenaline or any other vasopressor or inotropic?
Yes, adrenaline and other vasopressor like phenylephrine can cause vasoconstriction very well. We know very well. So you should avoid adrenaline and phenylephrine vasoconstriction. Dopamine is a good option. Yes. Dobutamine and dopamine.
Hello.
Hello.
Dipika, madam, this is Dr. Bhargav here.
Okay.
Madam, I wanted to know what is the protocol in your institute regarding anticoagulation during the intra period?
Yes, in every institute there is a different protocol. We have two plastic surgeons, and they both have different protocol. One is Dr. Hemant Saraya. He's a very expert plastic surgeon, and he used to injection heparin intravenously, 2000 unit in IV, and 3000 unit they just heparinize the vessel, and he was advised to give dextran intraoperatively previously, but nowadays he is very expert and he is not giving an heparin intraoperatively and even dextran also. But our one plastic surgeon is nowadays giving heparin 100 unit before harvesting the flap. So different plastic surgeons are using their own protocol, and yeah, heparin is, I think, there is no role for the to prevent the thrombosis. But better plastic surgeons can give this answer.
Anything about low molecular weight heparin?
Yeah, nowadays our plastic surgeon is giving Claxen for 0.4 milligram post-operatively for 5 days. But still, my expert plastic surgeon is not using nowadays. Nothing.
Okay. No role of intraoperative low molecular weight heparin.
Yeah, no. He's very expert and he's doing very well. I saw the slides, and he's all surgeries are done by him only.
Okay.
And very good results. And yeah, intraoperative technique is very much important. Intraoperative anastomosis is very important.
Thank you, madam. Thank you so much.
Thank you.
Ma'am, one more question.
Yes.
Ma'am, when do you ambulate the patients, especially free flap patients? I mean, is there any negative impact on of early ambulation on survival of the flap?
Generally, head and neck cancer, microvascular flap.
Yes.
Patients are ambulating next day only in our institute. Yeah. So it is good if you are ambulate early to these patients.
This one question in chat box. ERAS protocol and a pre-operative NPO advice.
ERAS protocol I don't know about for head and neck cancer surgery, frankly. But yeah, we in our institute we are giving a clear fluid before 2 hours. Yeah, we prefer to.
Okay.
Thank you very much, madam, for giving us your time and effort and providing us with such useful insights in flap surgery patients. So moving on to our next talk, use of opioid in cancer pain and current trends in opioid-free anesthesia by Dr. Sushma Bhatnagar. Dr. Sushma Bhatnagar is Professor and Head, Onco-Anaesthesia, Pain and Palliative Medicine, IRCH, NCI, All India Institute of Medical Sciences, New Delhi. Madam is Chairperson of COVID Services, NCI Jhajjar AIMS. She is IASP Council member, elected globally since 2016 for 6 consecutive years. She's been nominated by ASCO Women Who Conquer Mentorship Award 2020. She has a teaching and research experience of 31 years. I extend my warm welcome to you, ma'am. And I thank you once again.
Good evening. First of all, I would like to congratulate President ISA Nagpur branch and Dr. Himanshu for organizing this workshop, and also would like to thank them for inviting me to talk how can we create a balanced use of opioids in cancer pain patients and perioperative period. So what I will do, first of all, there is nothing to disclose. Whatever I will speak with my own experience. We will learn that why do we want to discuss why we need to learn opioid uses. So there are 3 reasons. Opioids are most effective analgesics for severe pain, which we know, and they remain the mainstay of acute and terminal cancer pain treatment. Irrational use of opioids is harmful, and there are a lot of incidents now all over the world that irrational use of opioids has created opioid epidemic. Overuse and misuse is becoming a challenge in various parts of the world. So this is important that we have to learn how to use opioid judiciously. What we will need to do now, we should improve education at mainly 3 levels: physicians and healthcare team, patients and caregivers, and we have to improve the education at public level. So first we will learn how to use judiciously in perioperative period, and then we will go back to the cancer pain patients. In perioperative period, what should be our approach? We should use multimodal analgesia plus minus opioids. So what is our experience from 2018 to 2020, the total number of patients in 1 year we have operated is 2,471. Out of these patients pre-operatively, only 136 patients were on pre-operatively, they are on opioids, and this is the distribution. Maximum patients required laparotomy. What is our experience in acute pain management services? Patient discharged on opioids were only 98. Out of 98 patient, because the patient those who were on opioids, progressive disease and inoperable patients were 37. Extensive surgeries were on 61. All these patients we have followed up in OPD and stopped these opioids in 1 to 2 weeks. So we have taken the responsibility that people, those who are inoperable and they need opioids for pain management, we should be following up those patients, and especially those patients, those who are having extensive surgeries, it is required that they will not need opioids forever. So we have stopped after 1 to 2 weeks. Although the progressive disease patients, they continue to take opioids. Key finding to work towards optimal opioid stewardship is multimodal analgesia, enhanced recovery pathways, and regional analgesia. This is an article published in Anesthesiology for, again, this is for perioperative opioid administration, critical review. What are the key findings of these articles? That opioid-free strategies, however noble, that we should not use it in their cause, do not fully acknowledge the limitations and gaps within the existing evidence and clinical practice consideration. Second important finding, they do not allow analgesic titration based on the patient needs. Third important finding, they are unclear about optimal components and their role in different surgical settings and perioperative phase. And fourth finding, important finding, they do not serve to decrease the risk of persistent opioid use, thereby distracting physician from optimizing pain and minimizing realistic long-term harm. So ultimately, the key finding says that there is no clear-cut evidence that we should not be using opioids at all, but we have to learn use opioid use. This is again the guidelines for safe use of opioids, led by Tata Memorial Hospital Group, Raghu, and Raghu, Dr. Divetya, and Dr. Sohan, or everyone together met with, we were also in the group, and we have created a guidelines for safe use of opioids. And again, they give emphasis that multimodal opioid sparing analgesia. For breakthrough pain, we can use rapid short-acting opioids. Large supply of opioids for home use or for medication at discharge should be avoided, especially in post-operative period. Strict instruction should be there for opioid return if there are disposal of for unused medication. And this committee again advised that there is a need to learn safe and judicious use of opioids at every level in perioperative period. Now we come to safe use of opioids in cancer pain patients. So there are two important things, that only opioids is not the opioids, although are mainstay of cancer pain management, but for all the pains, opioids are not the only medication which is required. So this is important to learn total pain concept, because in our one of my research scholars has done the study on total pain, and what we have found that in cancer pain patient, which is so severe and excruciating, only 35.5% patients, the component is physical pain. Rest all pain is psychosocial, spiritual, and social, psychological and spiritual and social pain, which should be dealt by different skills, by good communication skills, because this is not the pain where we will need opioids. So we should know how to take care of patient as a whole by a holistic approach. And there are, if at all, for physical pain we want to use opioids, we have created an opioid safety circle with 10 steps. So what are the 10 steps which we have published, and we are using and we are practicing this? The development of trust between doctor and a patient whenever patient is on opioids is very important. Creating awareness of safe use of opioids to patient and their family members that this medication should be used only for this patient or for this pain. Empowering physician, we have seen a lot of pain practitioners, they don't know how to use opioids safely. So it is important that by providing good teaching and training, we should empower physician. Assigning responsibilities, when medication we are dispensing for home use, who will be the responsible person? If medication are there stored in the hospital, who is responsible for safe storage? So assigning responsibilities is important. Fifth important point, making it available all the times, because when a patient is in severe pain, it is important. Cancer pain is severe and excruciating, and whenever patient needs, it should be available all the time, 24 hours in a day. Educating society, because there are so many myths and misconceptions about opioids, so educating society is important. Safe dispensing practices, because when which is also given emphasis in the society of onco-anaesthesia. They have given emphasis that when patient is not able to use all the medication, how they will dispense, how they will return, there should be a clear cut practice. Supervision should be there all the times. When you are prescribing first time, when patient is in follow-up, and when patient is not requiring, there should be a constant supervision and follow-up. Learning total pain practice, like I have already told, that all the pains are not going to be responsive for opioids. So learning safe opioid practice is important by taking holistic approach and conjoint intervention, because there are many pains which can be taken care by giving blocks. For example, a pain patient is having single lung metastasis or rim metastasis should be dealt by intercostal block. A patient with having carcinoma tongue and having localized pain should be dealt by giving glossopharyngeal block. So similarly, a carcinoma pancreas or a carcinoma gallbladder patient, if pain is localized, we should give celiac plexus block. So these are the example. By giving these intervention, we can reduce medication and we can avoid unnecessary side effects. By creating or spreading awareness is again a very good way of making patient pain free. This is what a noble initiative AIMS has taken, where we are treating pain as we are assessing pain as a fifth vital sign, and we are teaching and training all resident doctors that how to take care of mild to moderate pain. And when pain is severe, there are pain resource team in various wards for various wards, and they are going and treating pain. So this is our mandate, that all the registered patients, whether they are on OPD basis or indoor basis, we will take care of pain, and there should not be a single patient who will remain in pain. And all our patients, those who are registered in AIMS, they should remain pain free. For this, we have empowered our nurses, because nursing power we always underestimate. So what I recommend, that all of you should teach and train your nurses, because nurses are going to be there all the time. If you are starting opioids, for example, or a single patient, and if your nurse is trained how to titrate, how to monitor, what are the things they need to monitor, what are the things they have to explain to relatives and the patient, I think this will become a very successful program. So we have started LNEC program all over country, and various parts of the in various parts of the country, nurses has already been trained. So please use this underestimated power. This can create wonder, and teach and train your nurses in your hospital if you really want to create a safe opioid dispensing practice in your hospital. Make your own protocols where communication, educating patient and physician, communication, taking consent, making them comprehensive practice of pain assessment. Whenever you are starting opioid, revisit, monitor, and make it a practice that you are going to use. So follow up your patient judiciously, and follow up your patients, and make a system where we can create a judicious use of opioids. We need to do something for these little angels. You know, these are the two boys which we have treated. If we will not learn how to use opioids safely, how can we give them pain relief? Because they are not going to be, paracetamol is not going to work. Ibuprofen paracetamol combination will not work. The only thing which will work, tramadol we cannot give. Only thing which we work is low dose of opioids. If you will not learn how to use opioids for these children, how will you make them pain free? You cannot give blocks to these children. So what block you will give when they are crying in severe pain? So this is important that we should learn how to use opioids safely in perioperative period, in cancer pain patients, across all the ages, right from the pediatric to geriatric age group, how we can use opioids safely, how to titrate, how to monitor, how to follow up, to do the follow-ups. For this, we have created a lot of systems. We have created a software in our hospital so that we are monitoring our patient with a single UHID number. We can find out that these many medication this patient has taken, and whether if we are having slightest of suspicion, we are talking, we have a set questionnaire where we are asking whether they are using, nobody else is using in their at home, and how many medication, how many tablets they are taking. So with all these good follow-up system, we can create an environment where we can use opioids safely. So, but there are barriers, and what in a systematic way of doing survey, what we have found that these are the barriers in prescribing opioids. The biggest barrier is lack of information about policies. Nobody in the, I think, I am not sure that the audience, those who are here, they have any idea about NDPS amendment. So draconian law of NDPS, Narcotic Drugs and Psychotropic Substance Act, has been amended. And now it is very easy to procure. Only thing we need to learn how to store and how to make it dispensing practices, how, what are the requirements, what are the record keeping requirements required for for dispensing. This is definitely, there should be a clear cut information about these safe dispensing practices. Then there is a second barrier, what dangerous adverse effect, because whenever we talk about opiates, we are always worried about side effects. What are the medication in the allopathy which does not cause side effects? There are, every medication has side effects. Only thing we have to make ourselves phobia free about the opioid side effects. Addiction, we always think whenever we are prescribing opioids that patient is going to be addict. If a patient is in the terminal stage of the disease and if he is getting pain relief with opioids, I think we should use it. We should not be worried about addiction, because your constant follow-up and supervision will make it, definitely there will be no chance of addiction. Then administrative burden of record keeping. We are always worried that how we will, who will do this and taking care, be looking after the record keeping, and who will look after this administrative burden. So by this, I think we have started a pharmacy course in Indian Association of Palliative Care. So you can, and your pharmacist can enroll. We will teach them how to store, how to procure, and how to make a safe dispensing practices. So it is not a very big thing. We are doing so many record keeping, and we should not be worried about this record keeping. It's a very simple procedure. We can teach and train your pharmacist, your nurses. So we are starting this course right from in February. You can go to the IAPC website and see, and you can enroll your pharmacist and nurses for this, so that you will be relieved with this administrative burden. And lastly, people are worried that if there will be a slightest of default in record keeping, they will law enforcement will be there. But NDPS Act 2014 will definitely safeguard you, because in this clearly they said that if your record keeping is if you are practicing, and if you are using medication for cancer pain patients or for any terminal stage of the disease, you are safe. So it's not going to be that difficult as it used to be in the past. So India, I can say, is successful in implementing uniform guidelines through NDPS Act 2014. Now Indians or all anesthetists or pain physicians must spend their energy to learn, teach, and practice safe opioid use. So there can be misuse, but by practicing safe opioid use practices, we can balance use versus misuse. Otherwise, we will remain worried about misuse and all our patients will remain in pain. So our responsibility is that not a single patient should remain deprived of pain management. If they are in pain, they should be having opioid available at their doorstep, because this is a very low cost, safe, effective medication. And only thing which we have to do is we have to improve our knowledge, create our own protocol, because there is a protocol at AIMS, something is there, a protocol is at AIMS, but we have to create our own, because it is basically system based protocol. And DPS Act is one where you have to have a uniform rule of storage, procurement and dispensing. But for safe use practice, you can create your own protocol, so that it will become imperative that all the patients, those who are suffering with cancer pain, you will be able to provide medication with using safe opioid use practices.
Thank you, Sushma Madam, for a wonderful talk. You have nicely touched upon the multimodal analgesia, the use of opioids, which is required for a very progressive disease. And as you rightly said, opioids are needed for the breakthrough pain, which have a very rapid onset. And you underlined the importance of understanding pain, the total pain concept and the holistic approach. You have also said that good teaching and training of the physician regarding the use of opioids, I think that is the mainstay. And there is a very thin line between the use and misuse of opioids in our country. Safe use of opioids, even if it is terminal, I think very nicely recommended for using it in the terminal phase of illness, especially cancer patients. Any questions?
Just a minute. Good morning, madam. This is Dr. Cham.
Yes, good morning, Cham. And thank you, Dr. Kiran, Dr. Himanshu, Dr. Cham, for inviting me. And I know so many now new people. Sheila, Daksha. Oh, Daksha is also there.
Hi, madam.
Hi.
Good
Thank
morning.
you very much.
Nice to see you
Good morning.
after so much long time.
Good morning. Good morning. I'm so happy to see everyone. Thank you. Yes, Cham, please go ahead.
Yeah, it's very nice talk, madam. I understand from this that we have to use very judiciously the opioids, but I think the use of opioids in chronic pain is very much, and we can reduce the use in anesthesia, but it is very difficult to reduce the use of opioid in chronic pain. Is it, madam?
Yes. So chronic non-malignant pain, it should be avoided, definitely. But in chronic non-malignant pain, if there are some acute incidents, we can use for a break, like for a small one incidence, but it should not be used regularly. Ideally, for non-chronic pain, we should try to use non-pharmacological therapy and other therapies. I will not recommend for chronic non-malignant pain for long-term opioid use. Short-term you can give for severe pain, but not long-term, because there can be, but definitely if there is acute incidence in chronic pain, and if you think that by giving one dose patient can be relieved, I think we should use it.
Madam, do you recommend use of fentanyl patch or buprogesic patch in
Yes,
post-operative?
fentanyl patch is similar as it's we are regularly using. The people, those who get a lot of side effects from morphine, we are using fentanyl. Like a patient, for example, if patient is on 60 milligram of morphine, we use 25 microgram of fentanyl patch, and it is very effective. Buprenorphine definitely is a good analgesic, but we don't recommend, and all the literature is also not recommending for cancer pain management because of long-term side effects. So and acute side effects. So we don't use buprenorphine for cancer pain management, but definitely morphine and fentanyl are the two. Even methadone is available in India, and methadone is also again a good analgesic, very cheap analgesic. Very easily affordable for the patient, but we need a separate training and teaching for methadone. So maybe sometime we can learn how to use methadone by doing methadone workshop or something. because methadone is again a very good analgesic which is available in India in these days. And the same NDPS Act, every opioids drug, they come under same NDPS Act. So any person, any doctor who wants to treat cancer pain patients or acute pain in perioperative period, they can have, and they can procure these medication with very simple rule. We can do something on NDPS Act also. If you want, we can teach NDPS Act also. And as I told you, that pharmacist course we have created. So if you really want to make your system very safe, you can ask your pharmacist to enroll that course. It is a very simple course, just half-day course, and it will be available online. So they can come and they can learn how to, mainly our focus will be that everybody is afraid that what is the uniform rule all over India, because now it's a uniform rule, but nobody knows about uniform rule. On World Anesthesia Day, I did a teaching and training on this, and what I realized that all the anesthetists are using morphine and fentanyl intraoperatively, but they don't know how to procure and how to store. They don't know any rule. So it is important that all the anesthetists, they should be well versed with the NDPS Act. What is the recent guidelines and what are the recent rules? So we can cover that also if you want some time.
Thank you, madam. Now over to Himanshu for the chat box question.
Yes. Good morning, ma'am.
Good morning.
There are a few questions, ma'am. Breast cancer surgeries, as it is known that to cause acute as well as chronic pain. So can you guide us about perioperative pain management for breast cancer surgeries? So
in breast cancer surgery, we will not a single patient we give any opioids, because paracetamol and NSAIDs are enough, because it's just a pain will remain only for a day or two. And most of the time in these days we are using perioperative blocks. So that is again a very important. So we practice, we don't use opioids for breast surgery.
So do you use any agents like pregabalin from pre-operative period for prevention?
One of my first DM student, you must be knowing that we have started DM Onco-Anaesthesia in first time in the world.
Yes.
So first DM Onco-Anaesthesia student was my student, and we did a thesis in this, that he used to give pregabalin in pre-operative period, and he compared this so there was no significant difference, but it's not a bad practice. We can use it.
Okay.
Madam, what was the dose? 75 or 100?
75 milligrams. 75.
Ma'am, and few onco surgeries are supposed to go for a longer duration. So do you use or recommend use of intraoperative morphine, and what is your experience regarding use of intraoperative morphine?
So intraoperative morphine is very commonly used, definitely, especially through epidural route we are giving, and fentanyl also we are giving many times. So it is very commonly used for all major surgeries. We give fentanyl bolus and 1 to 2 microgram per kg body weight. And morphine also we are giving sometimes 3 milligram or 6 milligram starting in commando surgeries. And we use it for post-operative period also. We continue to use in case required, but we make sure that we have a train that we do post-operative round till the time patient get discharged. So we make sure that all the patients, those who are on opioids, should be stopped before leaving hospital. So you must have seen our data that all the patients, those who were discharged on opioids, either were inoperable, they were already on morphine. So if a patient is inoperable and having severe pain, I think we have to continue.
Ma'am, one more question is there. Giving opioid-free anesthesia involves use of regional anesthesia or blocks, which most of the times may require a use of ultrasound. So does non-availability of ultrasound has some hindrance in opioid-free anesthesia?
No, it's not like this. It's not like this. I think this is a separate thing. I think ultrasound should be there always. If you really want to do or otherwise, this is a very important equipment which all anesthetists should have. We have ultrasound in OT, we have ultrasound in ICU, we have ultrasound in palliative care ward, in pain management ward. So separate places we have ultrasound, and in emergency also. So it is not that ultrasound is non-availability of ultrasound is an hindrance, but it is a good equipment and it should be available. It makes your life very easy by giving real-time visualization when we do through ultrasound. So I think success rate becomes really high when we use ultrasound for clots.
I mean, your take on use of steroids and magnesium instead of supporting opioids, or instead of using opioids?
Oh, we don't use steroids and magnesium for pain management in onco-surgery. This thing. Steroid, sometimes we give pre-op for not to have emesis post-operatively, especially in this breast surgeries, but not we don't use routinely. And there is a question about ketamine also. So use of ketamine as no, we don't use ketamine as an analgesic in oncology. No. Ketamine we use sometimes in intractable neuropathic pain in cancer patients, very rarely, but not an analgesic.
Just like a breakthrough agent.
Yeah, breakthrough agent. Yes. So if there are no questions, thank you very much. I'm really honored. And I see so many familiar faces, so it makes me more happy. And thank you, Dr. Kiran and Secretary, Dr. and Himanshu. First SMS Himanshu sent me, and Sheetal, I know now I know you also, Dr. Sheetal, and Cham, I know since last many years. So thank you very much, and everyone enjoy this workshop. And I'm really happy that you are starting this type of courses, because now very soon we are going to start 3 years dedicated DNB or DM Onco-Anaesthesia from National Board of Examinations. So I think Nagpur should take the lead in Maharashtra, and you should start a dedicated 3-year course, super specialization course in Onco-Anaesthesia.
Thank you.
Such an honor.
Thank you very much. Thank you. And I'm sorry I have to leave, because I have to join my national conference where I am president. National Conference of Indian Association of Palliative Care is going on, and I have to join that the conference as a validatory, because validatory function is at 12 o'clock. Okay.
Thank you.
Thank you very much.
Thank you, madam.
Bye. Enjoy the conference.
So much, madam.
We appreciate your efforts. They say divine is the task
to relieve pain, and you are doing one such job, ma'am. Thank you so much from ISA in Nagpur City branch. Moving on to our next session. Next talk is on anesthetic consideration for head and neck cancer surgeries, which will be presented by Dr. Sheila Myatra. Dr. Sheila Myatra is Professor of Anesthesiology and Critical Care, Tata Memorial Hospital, Mumbai. She is President-elect 2022 of Indian Society of Critical Care. She's Chair of Intensive and Critical Care Medicine Committee of World Federation of Societies of Anesthesiology. She is immediate past President, All India Difficult Airway Association, and she has over 100 index publications and over 40 book chapters. Over to Dr. Sheila Myatra.
Hello, everyone. Greetings from Tata Memorial Hospital. Thank you very much, firstly, for that very kind introduction. It is indeed a great pleasure for me to speak at this ISA webinar. And being from a cancer center, I'm delighted to see this kind of onco-anesthesia session that has been arranged. At the outset, I'd like to thank the Indian Society of ISA Nagpur branch for giving me this opportunity. Dr. Vagmare, Dr. Joglekar, and the entire team of ISA Nagpur. Thank you so much for the kind invitation. And of course, many thanks to Dr. Cham, a dear friend, and also Dr. Marathe and Dr. Bhargav, who have organized this session. So thank you very much. I bring you greetings from the Tata Memorial Hospital. I will be speaking on anesthetic management of head and neck cancer. If I may just be allowed to share my screen. So though it is anesthetic management, the large focus in head and neck cancer, of course, is the airway management. I have been disabled from sharing the screen. If yeah. So I will be focusing largely on the aspects of the airway management, which is really paramount in the anesthetic management of these cases, and also focus on some other aspects. And I'm happy to take questions at the end of the session. If I may just be enabled to share my screen.
Yeah, just a minute.
Yeah. And again, I'll talk about, head and neck cancer itself is, we have series of lectures in this. So I'm going to give you a broad overview and largely speak on my experiences in the last 23 years at the Tata Memorial Hospital. And a lot of things I would like to share with you, which as an anesthesiologist, I did not know when I came from doing my MD anesthesia in Sion Hospital. There were a lot of things specific to cancer that I was not aware of. And I learned as I went along. I hope you can.
Yes.
Okay.
First,
yes, thank you so much. So first of all, apologies for taking this talk right at the end, because I was supposed to take the second talk. And Dr. Bhatnagar has just exited for her meeting and I have just entered from that meeting. So, a cancer session and a palliative care conference meeting are happening concurrently. So I will be talking about this. So first of all, as I mentioned, as all of you know, I work at the Tata Memorial Center. This is the Tata Memorial Hospital, and this is the Advanced Center for Research and Education in Cancer. This is our hospital. And as you are all aware, head and neck cancer, among the cancers, head and neck cancer is the highest in incidence among all the cancers. And among these head and neck cancers, it is the oral cancer. And that is because of smokeless tobacco. And we know this is a different challenge in India. If you see in the Western world, because of smoking, they have more of lung cancer. We also have lung cancer, but the incidence of oral cancer is much higher because of the, the tobacco chewing and people keeping, tobacco at, in their mouth and certain areas for longer regions. And as you know, you get tobacco not only in the raw form, but also your gutkas. And there had been a ban in Maharashtra, but we still see people taking it in various forms. And unfortunately, because of this, the incidence of oral cancer is very high. You can say 30% of the cancers are head and neck cancers, and among them, almost 50% are oral cancers that we face in India. And unfortunately, these patients, especially at Tata Memorial Hospital, being a tertiary cancer care center, they present quite late. So because of this, they have big airway lesions, and all this makes airway management really challenging and really difficult. These are our operating rooms, and we have high volume of head and neck cancer theaters that are dedicated to head and neck cancer, almost 5 to 6 operating rooms running per day. And I think my talk is more important for not for a person who's routinely doing these cases, but more importantly for a person who occasionally does head and neck cancer cases. Because there are some very specific things about the anesthetic management which will be quite helpful. And I hope my talk and sharing my experiences will be useful to you. So we face some unique challenges when we, with the airway management in these patients. So you're worried about actual or potential airway obstruction, actual or potential loss of the airway. There can be difficulty of ventilation, difficulty in intubation, and then you're sharing the airway with the surgeon, and even your post-operative airway compromise. So the job doesn't end when the surgery is over. The post-op period also can create a lot of problems, and especially for people who work in smaller places, nursing homes, etc. You have to keep this in mind because you may be called back if there's a complication. So you want to make sure when you're leaving this patient after the surgery is over, the patient is absolutely safe and fine. So the requirements also are challenging because you need very good depth of anesthesia, suppression of the reflexes, because you're working on the airway. So you can't have the patient even moving slightly, but you at the same time, you need rapid recovery of your airway reflexes. You want the patient coming back, spontaneous breathing, conscious after surgery, because you want him to maintain a patent airway. Unobstructed quiet field is required. So you need to secure and protect the airway and maintain gas exchange at the same time. And the other very worrying problem is the bleeding and secretions during surgery. But at the same time, we need to ensure a clear airway at the end of surgery. So these are some of the conflicting requirements that we faced in this kind of unique film. So what is really paramount, and something I learned as I went along, is the teamwork in this kind of surgery is extremely important. The planning, the preparation, and the communication. Never work in isolation. The plan goes on changing. What the surgeon does is changing. If he is not communicating with you what you are thinking, you've lost, your cuff has got punctured, you need to change the tube. You need to communicate really well. I would say not only with your surgeon, but the entire team, even the nurse, the things are required, some instruments are required. So it's really about not only advanced planning and communication, but communication throughout the procedure. Because things keep changing, the patient, the dynamics of the patient, the surgery, what's happening, the blood loss, everything can change. And so this, and more importantly, you cannot make one formula for all patients. So you can have a general protocol. Each patient has to be considered according to the level and the nature of airway pathology. What is the obstruction, and also the individual clinical circumstance. Now, pre-operative assessment, many people take this very lightly because they say, "Arey, ye to surface surgery hai. What's the big deal? Only the airway is the problem." But these are chronic tobacco chewers, and many of them also consume alcohol. And this leads to significant cardiopulmonary disorders. I won't go into details of that, but keep in mind that these people have a lot of other associated problems. Now, the tumor interferes with eating. You have a small ulcer in your mouth. You cannot even eat properly. Can you imagine these people with big fungating lesions? They have weight loss. They are bleeding from those lesions. Anemia is there. They are extremely dehydrated when they come for surgery. So hypovolemia is present, and electrolyte imbalance is often present in these patients because of this, poor hydration and lack of, not eating adequately. Now, we only look at this during coelomic surgery. We don't think of this during surface surgery. But trust me, head and neck patients, they are so dehydrated when they come. You must hydrate them before you start the surgery, because the moment you give that propofol and this thing, you have precipitous fall in blood pressure. They are very, very dehydrated when they present for surgery. And this is something I learned actually along the way. I didn't imagine that someone coming like this for a surface surgery, and it's because of the poor intake. The other things you have to keep in mind are the previous therapy. Previous surgery, chemotherapy related, specific complications, and radiotherapy. Now, radiotherapy is a very big flag. No anesthetist looks at history of radiotherapy, having received radiotherapy. And I really burnt my fingers along the way learning about this. Now, when someone has a previous surgery, obviously you're assessing the airway. A person like this, he has a commando surgery already done. Part of the mandible is removed. Just looking at him, this airway is going to be difficult. Mask ventilation is going to be difficult. Intubation is going to be difficult. He couldn't open his mouth completely. So I had planned an awake tracheal intubation in this patient. I'll tell you, this was the first emergency cricothyrotomy I did in my life after coming to Tata Hospital. And, rightly so, I knew this was a difficult airway. So I planned an awake fiber optic intubation in this patient. Now, in this patient, to facilitate that, I gave this patient 1 milligram of midazolam, to sedate him. Now, that 1 milligram of midazolam, he stopped breathing. So catechic this patient was, so dehydrated. He stopped breathing. I could not ventilate him. I could not intubate him. And then we had to do an emergency needle cricothyrotomy. And fortunately, the head and neck surgeons were there, and they immediately followed it up with a tracheostomy, and we were able to rescue the situation. But I'm just trying to tell you that you have to be very careful, even with awake techniques, the kind of sedation you're giving, because you have to distinguish between a patient who just has a difficult airway and someone with a compromised airway. So, while you're doing an awake intubation, because it's a difficult airway, remember that if there's any respiratory depression or patient stops breathing or anything happens, you will not be able to secure this airway easily. And therefore, having a backup plan is a very, very important part of anesthetic management of head and neck cancer, because you might have unanticipated problems even when you are doing awake tracheostomy. Now, previous radiation therapy. Now, I'd like to focus a little bit on this because we are not taught this during our anesthesia training. Now, radiation given to the head affects every part of the airway. Radiation of the temporomandibular joint leads to trismus. There can be functional ankylosis due to pterygoid and masseter muscle fibrosis. The epiglottis is often swollen, immobile, and this makes the exposure of the larynx difficult. There may be necrosis and fibrosis of the larynx as well as vocal cord. So, when you do laryngoscopy, the anatomy looks, the cords look so indematous. Remember, may need a smaller size tube. And radiation near the floor of the mouth makes this tissues area very non-compliant. So it's not about using a video laryngoscope or using a direct laryngoscope. Even with a video laryngoscope, the exposure, the anatomy, the fibrosis, everything can make this tracheal intubation extremely difficult. So radiation is often a red flag. And as you can see, earlier when patients used to receive radiation, you could just look at the neck and you can say, oh, this patient has received radiation. Today, because of all this IMRT and, very specific areas that focus on, you don't see this kind of staining on the neck. So you will not even know unless you see the history. And every part of the airway is affected. They even lose their teeth. So they have poor dentition, the fibrosis, the edema. And often the anatomy looks so distorted, you may not even be able to identify the structures carefully. So whenever you hear that this patient has received radiation to the head and neck region, remember smaller size tubes, this is going to be a difficult intubation. And even the tracheostomy is difficult for the surgeon. There's a lot of fibrosis and tracheostomy itself can be difficult. So this can, should always be a red flag for you. Now, I'll start with intraoral lesions. Now, when you look at intraoral lesions, often they can have distortion of the face. This can make mass ventilation difficult. Mouth opening, there can be trismus. Now, this is a very important question to ask. Is there trismus? Their oral hygiene, dentition, obvious fibrotic bands. What is the size, site, and the extent of the lesion? And if there's tongue, then whether they go to the base, they cross the midline, is there ankyloglossia? So most people say, oh, mouth opening theek hai, video laryngoscope jayega, DL scope kar sakte. But what is important is head and neck patients with intraoral lesion need some more extra airway assessment other than the routine airway assessment. And I'll come talk to you about a minute. Now, especially these post-RT kind of patients, chronic tobacco chewers, very poor, loose, missing teeth, which itself can make your airway management difficult. Now, trismus is an issue. And remember that you have to I worked in a trauma center at Sion Hospital before I came to Tata Hospital, and we used to have a lot of maxillofacial trauma. So these kind of patients also had trismus, but after you anesthetize them, the mouth would open wide. Remember, the trismus that you see in cancer patients is not the same. There is some element of inflammation that may, open up the mouth a bit, but largely it is because of the submucous fibrosis. And just keep in mind that this mouth may not open at all. So you must have that kind of preparation. And you can see patients with fibrous bands like this itself can make your laryngoscopy and intubation difficult. So important question to ask that will the trismus be relieved? As I mentioned, there's painful trismus and painless trismus. So these patients also have some inflammation is there, so it's not completely that the trismus is because of the lesion itself, but painful trismus due to the inflammation or some infection that they may have, this only can resolve with GA. But the painless trismus is due to the submucous fibrosis, the radiation-induced fibrosis of the TM joint, and also the infiltration of the tumor into the inferior infratemporal fossa and pterygoid muscle. Now, this will not improve with GA. And remember one thing, that every head and neck patient who comes to you has a CT scan done. We don't look at this CT scan. Look at the CT scan. Look at the infiltration of the tumor. When you see patients with trismus, there's also, here you can see the disease is infiltrating. So it's very good to discuss with the surgeons rather than just say, okay, this patient has trismus and the mouth is not opening, so that you can know the extent of the disease. There are different grades of trismus that are present. So depending upon how much the mouth or inter-incisor distance, and then you can classify if it opens less than 15 mm, and this is the 1.5 centimeters, then of course it has implications for us in terms of even performing the laryngoscopy. Now, when you come to tongue lesions, we need to look at mouth opening, the dental hygiene, of course, as fibrotic bands, as I've already shown you. Now, ankyloglossia becomes very important, and lateral deviation of the tongue. So don't just look at mouth opening, ask them to protrude the tongue. And if they can't protrude the tongue, these are advanced lesions. Look at the site. If you're using direct laryngoscopy, if the lesion is on the right side of the tongue, these will bleed during a DL. What is the extent? Is it extending to base tongue? Right lateral border, as I mentioned, bleeds. If the disease is crossing the midline, these are extensive lesions, and these are likely to be very difficult cases. If there is, ankyloglossia, again, that should be a red flag. Is the tongue deviated? So if the tongue is deviated, lateral deviation of the tongue, that means the lingual and all is also involved, and these are extensive lesions. So this gives you a very good idea about the extent of the disease and helps you make the airway plan. Now, remember, these lesions, don't just look at mouth opening, because people now, because they have video laryngoscope, they think, oh, mouth opening is good and video laryngoscope will be fine. These lesions, they bleed heavily during laryngoscopy, creating problems for mass ventilation and, of course, subsequent attempts at intubation. And they may not allow the Macintosh blade to enter the valvula itself. So this, a discussion with the surgeon about the extent of the disease is extremely important. Remember, whatever technique you use, your video laryngoscope or awake fiber optic intubation, blood and secretions are the enemy for these devices. So the decision to do an awake technique should not be as a rescue. You cannot use these devices as a rescue. The plan to do an awake fiber optic should be upfront. It shouldn't be after it has failed, because it won't really be beneficial. So careful assessment, and not only looking at mouth opening, but the extent of the disease. Is it right lateral? Is it extending to the base? Is there ankylosing? Is there lateral deviation of the tongue? All this is very important to plan upfront an awake tracheal intubation, rather than attempt laryngoscopy, have bleeding, then get into a messy situation. The airway imaging can give you, as I mentioned, lot of useful information. When you have, coming to especially laryngeal lesion, things that you cannot visualize, you can have a very good idea. So, we are by our kind of practice itself, we think, okay, surgeons have seen the imaging, we don't bother. But when it comes to head and neck cancers, we should definitely look at the imaging and look at them. I'll tell you something very simple, how airway imaging can help. And this is your, the tracheal tubes, and you can see the most distressing thing that can happen is when your cuff gets punctured. So you do this very difficult intubation and you ventilate and you see, oh my God, there's a big leak. And now you have to change over the tube. So this can be very, very frustrating to do. Now, a lot of time this happens. And, we did a very simple study. We looked at 30 cases in which there was cuff puncture. And we went back and looked at the CT scans of these patients who had a cuff puncture. And interestingly, 90% of those who had a cuff puncture during surgery, which after intubation had a nasal spur on the same side. So we could have completely avoided this and used the other nostril. The point I'm trying to make is that look at the CT, look at the image. Look at whether there's a nasal spur or not. Now, before doing a nasal intubation, I always check the CT scan. If you're not able to interpret, I ask the surgeon, is there a spur on either side? And I use the opposite nostril. Of course, you can do a clinical examination, but things like spurs you will miss. And this is very, very useful information, because you don't want your cuff to get punctured. And this is something simple that we have started doing now in our clinical practice. Airway imaging gives you a lot of useful information. Your x-rays help you look at the size, the site of the lesion, whether there's any compression, deviation. Scans of CT scan, of course, is better because you can get a better idea of the extent of the disease. And this can, help you, plan your anesthesia, the size of the tube, decide whether awake or sleep technique. Ultrasound was already mentioned, and this is very important, especially when you are anticipating a difficult airway, because your pre-op ultrasound neck can be performed, and this can help you identify the cricothyroid membrane. Where is the anatomy? Now, sometimes because of nodes, it may be deviated, and this can be extremely helpful, especially when you have, if your plan fails and you have to move to an emergency cricothyrotomy, like I mentioned, you can mark and keep the cricothyroid membrane. So you're already prepared, you're already ready. So ultrasound preoperatively can help you, other than, of course, looking at the neck node and other structures. Virtual endoscopy is a new tool in our armamentarium. So this is basically what it is a radiological simulation of the anatomy of the airway, extending right from the oropharynx or nasopharynx up to the carina. So you can just take any CT scan that you already have of the patient, and there's a free software, Osrix that is called, and you can just download this. If you're not familiar with this, you can, so the radiologists know of this, but the radiologists don't know about virtual endoscopy. And then you just upload this. So you get a full fly through, like a 3D, as if you're walking through the nostril and going up to the carina. So you get a beautiful fly through of the entire airway anatomy. And this is very nice, because if you're planning a fiber optic intubation, you can get it's like you're walking through the entire path. So whatever's coming in your way, you can have an entire view of this, like it's like a walking through the path. And you can often, you might change your plan. I might say, no, I don't want to go from the right side. I'll go use the left nostril. Or you already know that in this area, you'll have to move this, so it gives you a good kind of idea. And this is a new tool that we have in our armamentarium. Now, one important thing I want to tell you is look at the diagnostic airway procedures. Patients don't come for these cancer surgeries straight away on table. There's always some DL scopy, ML scopy, FOL, IDL, something done in the in the OPD would have been done, or some minor procedures they come for. So look at the information related to this, and this gives you a lot of idea. Sometimes they're done under local anesthesia. So most important in this is that you should note the date of the procedure. So sometimes 3 months back something is done. You cannot go by those findings because the disease would have progressed. So in cancer, remember, whenever you see any of the CT scan or imaging or procedure done, note the date of the procedure. And this kind of findings from that procedure will give you very useful information to plan your anesthesia. Of course, the counseling is extremely important for your airway management plan, whether you're going to do a tracheostomy or not do a tracheostomy. What is the choice of airway management? Now, this is the discussion that you have to have. Some patients will need awake tracheostomy straight away. You don't have to be heroic and say, no, I'm going to do, every patient I'm going to do awake intubation. Discuss with the surgeon. If the disease is extensive, crossing the midline, I'll come to you, talk to you about how to decide whether to do a tracheostomy or not. Now, if you are anyway going to do a tracheostomy after your resection, sometimes the surgeon might want to do it upfront. So you can avoid that whole stormy intubation. Then you have to decide decision, which one am I going to do awake and asleep? This is extremely important, not only in head and neck, but in any airway management. All the problem that occurs when you cannot intubate a patient, you cannot ventilate, happens because we give general anesthesia. And because we have not made the appropriate decision as to whether you should do this awake or we should do it asleep. If you're doing it awake, are you going to do fiber optic? Are you going to use video laryngoscope, retrograde, or whatever other technique? But all this choice of airway management should be done. The type of tube, are you going to use flexometallic, your RAE tubes, or this thing? The peri-intubation oxygenation is very important because we want to prolong the safe apnea time. Now, remember, these intubations are known. They are anticipated to be difficult. So if you're giving GA, the conventional pre-oxygenation may not be adequate because, in case your intubation is difficult, you want to prolong your apneic oxygenation. That is a time before the patient desaturates, from the time of giving the muscle relaxant till the tube is in. So you might want to give, you can use nasal prongs and give 15 liters of oxygen soon after your pre-oxygenation. So you're giving oxygen during attempts at intubation. Or if you have Thrive, then you can use that. That can prolong your safe apnea time further. So definitely, when you have an anticipated difficult airway, you should use apneic oxygenation to prolong the duration, the time to desaturation in these patients, and make sure that you do very good pre-oxygenation for these patients. Don't hurry and just pre-oxygenate for 1 minute. Give adequate pre-oxygenation because these patients are likely to be difficult. I already talked about sedation, that you have to be extremely careful what sedation you are using in these patients with a difficult airway. We are very fortunate that we have dexmedetomidine. Dexmedetomidine is an excellent drug, doesn't produce respiratory depression, keeps the patient beautifully in conscious sedation. I start an infusion usually 15 minutes before I start an awake tracheal intubation procedure, giving about 1 mic per kg. Start the infusion. So by the time you're ready, you give your glycopyrrolate and the sedation infusion before this, and then you prepare the airway. And while by then these drugs would have gone in. So giving midas, giving fentanyl, all this, you have to be extremely careful, especially when they have a compromised airway. So this can be very difficult. I won't go into details of the anesthesia. That's not very this thing, but we give a balanced anesthesia. And intraoperative fluid management has got a lot of focus now, especially, and there's ERAS has also been extended to head and neck surgeries, especially because we're doing, you've already had a talk about microvascular surgery and the long duration surgery. So we cannot just say these are, surface surgeries and the fluid management is not very important. But I won't go too much into detail about all this because that's been covered. Excuse me. But that's by and large this thing. And then whether you want to extubate the patient or you're going to do a tracheostomy is another very, very important decision. And I'll talk about that a bit because this is really a challenge for us. Okay. Because now your surgery is over. And what are we worried about? The other challenge that I told you is the post-op airway compromise. Should I extubate this patient, or should the surgeon do a tracheostomy, or should I keep the tube overnight? So we have two types of practices. We either do a tracheostomy if there's an extensive resection. Depending upon that, we do a tracheostomy, or we keep the endotracheal tube overnight. We used to extubate earlier after a few hours, but now we have stopped doing this in the interest of safety. We don't do any night extubations. We extubate the coming morning. Because you have more staff present and you have more expert help, the surgeons are around. So if there's any doubt and the patient is not tolerating this extubation, a tracheostomy can be done in the kind of borderline cases. And you don't need to ventilate these patients when you keep the tube. But, the advantage of this intubation is that, whatever edema is present after the surgical resection, you have these extensive resections and then you have flaps. This can compromise the airway. There's edema. And then sometimes there can be some post-op bleeding that is there and you need to take the patient back into the OT, or the surgeon needs to see the drain or something like that. And here, if your tube is not there, airway is not secured, it might be very difficult because this is an even more difficult airway now because after the surgery. So keeping the tube overnight kind of helps everything settle. And then once in the morning, you're sure you don't need to give steroids or anything electively, but you can just do a leak test. You can extubate these patients very easily. Now, the real question and something that baffled me when I joined Tata Memorial Hospital was that in which patient do you do tracheostomy and in which patient can you safely do an overnight, put a tube and extubate. We obviously know about the benefits of extubation over doing a tracheostomy, right? Because the tracheostomy it's the safest thing, of course. Do a tracheostomy for everyone, and that will make airway management also easy and post-op airway also easy. But tracheostomy is not without complications. We know, especially with our nursing issues, that patients have blocked tubes, dislodged tracheostomies, a lot of complications can occur. It delays their oral, intake. The speech also gets affected. So it is a lot of morbidity, and complications could also be high. So we have to know which patients we can safely extubate. So this question really baffled me as to, why don't we have a definitive answer? There is literature showing that overnight intubation results in shorter stay, is good for the patient, and improves the recovery of the patient. But this had never been prospectively studied. And I'm very proud to say that along with our fellow and our team at Tata Memorial Hospital, we tried to address this question because we thought we were in a perfect position with the highest world volume of head and neck oral cancers. We said, let us do this study. So we published this in Oral Oncology in 2021. And what we looked at was identifying which patients were good for a delayed extubation strategy that I mentioned versus an elective tracheostomy for post-op airway management in major. And this is, of course, oral cancer surgeries in which we studied this. And I was very fortunate to do this over a period of 1 year. We looked at all the oral major head and neck cancer surgery, and we tried to answer this question. And I told you about the benefits of delayed extubation. It definitely, patient has faster recovery to speech and feeding. And also, if there won't be any airway obstruction post-surgery, you're not extubating them early. So there are definite advantages of a delayed extubation strategy. So coming to this study, what we did is it was a prospective observational study in a large cohort of oral cancer patients. And what we did is that we allowed whatever practices were going on, we just allowed them, to do tracheostomy in those they wanted to, safe extubation in those they wanted to. And post extubation, what we did is we looked at those which was safe extubation. And what was safe extubation? Safe extubation means you extubate the patient and they're able to maintain a patent airway. So after a few hours of extubation, they're able to maintain a patent airway, then this was a safe extubation. We took only adult patients. We didn't include minor surgeries. And we also looked at some quality indicators like what was the time to oral intake and what was the return of speech. So this is just showing you how many patients we had screened. Close to 5,000 patients were screened. We excluded minor cases, pediatric cases, and finally 720 cases were there. All 417 in delayed extubation arm and 303 in the tracheostomy arm. And we tried to look at which were the safe extubation. And these were just the demographic characteristics of these patients who undergone surgeries. I won't go into detail of this, but what we did is we looked at those patients who had a safe extubation, and then we did a multivariate analysis to look at what were the factors that were associated with the safe extubation. Now, in our patients, if you looked at the complication rates, the patients with tracheostomy had higher complications. The airway-related complications also were higher in patients with tracheostomy compared to those who underwent delayed extubation. And what was a very important thing is the location of the complication. Now, if you see delayed extubation, we had 7 complications, all occurred in the recovery room itself, because the extubation is done there, the patient is kept overnight, and the next day is extubated. He's observed for a few hours and then shifted. So here you have very good staffing and you can observe. Whereas if you look at tracheostomy arm, 22 of the complications happened in the ward, and this is very dangerous. Your blocked tracheostomies, your dislodged tracheostomies. So definitely delayed extubation is a safer strategy. And using our study, we did a multivariate analysis and we tried to identify the risk factors that were associated with a safe extubation. And this was, I'll just tell you the characteristics. So no neck dissection or a unilateral neck dissection. If it was tumor staging 1 or 2, there was no pre-op radiotherapy. Okay, conservative resection, I'll tell you what a conservative resection is. And if it was a primary closure or even a faciocutaneous flap was okay. If you had all these characteristics, you can safely plan for a delayed extubation. So just to tell you as an algorithmic approach that we used in a paper, if you have a major oral cancer surgery, if you have a tick for all these characteristics, so patient should be at tumor stage 1 or 2, no preoperative therapy. If you have all these characteristics, you can consider for a delayed extubation. Of course, there may be some individual variations, but none of the patients with these characteristics had a unsafe extubation. And what do we mean by extensive surgical resection? For a tongue, if you're crossing the midline and going into a near total or a total glossectomy, or if it's a mandibular resection involving the genial tubercle, okay, because that will affect your swallowing, or it's extended beyond, the middle or 1/3 of the mandibulectomy. And if it's a maxillary resection, then crossing the midline. So this is what we mean by extensive resection, but very objective anatomical criteria that you can use to decide whether, make a very objective assessment about whether you can extubate or not. In this paper, we were asked by the reviewers that, oh, this is India specific, this is Tata Memorial Hospital specific, but we argued that we are in the best position because we have advanced disease. So we have the entire range of disease, right from early lesions to late lesions, which the Western world never sees. So we are in the ideal position in India to answer this question. And I'm very happy that with my team, we were able to get this result. So the conclusion of this study was a delayed extubation strategy after major oral cancer surgery is safe, effective alternative, and it allows faster recovery of oral intake and also speech. And tumors, these are the characteristics which I've already outlined, and these can be used as a guide. So don't, allow your surgeon to do tracheostomy for all patients. Some of them can be safely extubated and they will have a better quality of life. Do I have another 5 minutes or shall I stop? Because I wanted to just talk on laryngeal lesions. Is that okay?
Oh, please continue.
You can continue.
Is that okay? So the other big challenge in the airway management is your laryngeal lesions, and these need some assessment. Remember, never anesthetize a patient who comes to you in stridor. Be very careful. The surgeon will tell you, come on, give GA. And these are the patients you can have complete obstruction, and be very careful about these lesions. Now, these lesions may come to you early for laser surgery, or they might come to you for the total laryngectomy. So here you can see this is a tumor that is coming out of the laryngeal inlet. So we have either the laser tubes that are available, they're expensive, not used in all centers, or you can use your red rubber tubes if you have them, which are covered with the foil for the laser surgery. So there are different strategies that you can use for these short surgeries. You can use a smaller size tube. So you can, or you can practice jet ventilation. You can put the jet catheter inside. And, when you put smaller size tubes, again, it comes in the way of the surgeon and the jet ventilation. Another practice that is done is that you can, do something called a apneic technique. So you allow the surgeon to buzz this entire lesion, and then you can intermittently put the tube, take it out, monitor the saturation. When the saturation falls, again, you put the tube back inside, ventilate for some time, and then you can allow the surgeon to this thing. So these are the different techniques that we can use. You can use this apneic oxygenation technique or intermittent ventilating the patient. Now, what does the surgeon need? Now, in all this, the surgeon needs 3 things. He wants, firstly, a clear field. Now, that is not achieved when you have this kind of tube in the way, or you have a jet catheter in the way. Then he needs muscle relaxation. So you're paralyzing the patient. If you're paralyzing the patient, he's not breathing, then maintaining his ventilation is a problem. And the third thing that he needs, he doesn't need interference. So when you're doing this kind of apneic technique, okay, saturation is falling, let me ventilate, he gets interrupted. So these are the 3 requirements for the surgeon. So, to facilitate this best, the apneic oxygenation technique can be used. And here, for example, this is a laser cordectomy where we will use the laser tube. But one technique that you could use is for laser. I will not advocate this because, this gives the surgeon the best technique, but this has to be done in centers where they have the expertise and understanding of the fire triangle, and the team is very, even in our center, there are very few people only who do this. So what you need is you are giving apneic oxygenation through Thrive, the nasal cannula, and there is no tube, there is no jet, no catheter, nothing. And there is also no interference with the surgeon. and you're also giving muscle relaxant, so the patient. So this is the ideal condition for the patient surgeon to work on. So you can use Thrive, and this is all of you are aware of how this works. I won't go into details of this in the interest of time. It's transnasal humidified rapid insufflation ventilatory exchange. For these laser surgeries, you need not use 100% oxygen. You can use lower FiO2s, but it can prolong your apnea time. We've gone up to 90 minutes without the saturation dropping. Of course, the CO2 does rise, but it doesn't rise to the same extent as when you don't ventilate the patient at all, because it produces this high flow that is given, your 60 to 70 liters, produces a ventilatory exchange and doesn't let the CO2 rise to that extent. But again, as I mentioned, if you're using this, you have to be very familiar with the equipment. You have to be very familiar with the fire triangle. Now, as you see, you have the laser source, so that's the heat. You have an oxygen-rich environment, but you have nothing that will burn. So people in the team have to be very careful. You can't just suddenly push in a tube or push in some gauze piece or push in something. So if you understand this, we have a timeout with our team, with the nurse, with the surgeon and the anesthetist, and we are very, very careful. And even if there's a fire, we know what we have to do. So only if you have this kind of understanding and teamwork can you use Thrive. Otherwise, I would not advocate to use it. But though the surgeon is very happy when you use this procedure. And I will just show you, this is just a case that we did last week. I don't know if this video will play. Yeah, so you can see that there's no tube in the way. Okay, and this is a type 3 podectomy. So you can have this kind of procedure done with muscle relaxant, giving apneic oxygenation without any tube coming in the way. So then the larger lesions, you have to make a plan when they come for major surgery. So either you can do awake, these are going to be difficult. So you can do awake fiber optic intubation, or do you want to give propofol and relaxant? Some of these cases like this, you have to do upfront tracheostomy. Now, they don't like to do tracheostomy in these patients. I often wondered why. And the reason is, if you do tracheostomy, you have seedling of the disease at the tracheostomy site. So onco-surgery, they try to avoid tracheostomy as far as possible. And many of these patients present in stridor. So you have to evaluate the size and extent of the lesion, very, very carefully. And remember here, the problem is not the visualization of the cords. When you do the laryngoscopy or video laryngoscopy, the vocal cords will be in front of you. The laryngeal lesion will be in front of you. So awake fiber optic intubation may not be a good idea because it can cause complete airway obstruction. Giving local anesthetic itself will be difficult, and sedation, as I mentioned, distinguish between a difficult airway and a compromised airway. Then, giving local, preparing the patient itself is difficult, and technically also is challenging because of the distinctive anatomy. And most importantly, the fiber optic intubation itself might precipitate complete obstruction of the bronchoscope. So you have to be very careful. Sometimes you can have complete obstruction because already the lumen is narrowed, and then you're going and putting the bronchoscope in, and the tumor itself may make the passage of the bronchoscope difficult. So giving awake intubation in these patients is quite difficult and challenging. So in this kind of situation where mask ventilation and intubation is considered possible, it's better to do, difficult, not considered possible, better to do elective tracheostomy. And when it is considered possible, like in these kind of lesions, you can give general anesthesia and you can ventilate them. But if you are you have to be ready for a cricothyrotomy if you have any difficult situation. And the last, just 2 minutes, coming to the upper and mid tracheal lesions. Now, these are, you don't see patients coming, but sometimes from tribal regions, you have patients coming with very advanced kind of lesion. Now, in these kind of cases, very important to look at any extrinsic compression, look at the imaging, look at the CT scans, look for deviation, look for compression, even to decide the size, size of the tube, and also intrinsic obstruction. Sometimes the disease also may be infiltrating into the trachea. And most importantly, you need to have a rigid bronchoscope as a backup. Never do these kind of cases without having a rigid bronchoscope, especially when there's extensive tracheal deviation and compression. And here you can see that she not only has deviation and compression, but also intratracheal extension of the disease. So what size tube are you going to put? Your entire planning. So visualization of the cords is not important. But the other very important thing you have to keep in mind is these are long-standing disease. They often have tracheomalacia, and you can, you give muscle relaxant and you can completely lose this airway. You can completely lose this airway. So whatever you have, video laryngoscope, fiber optic, nothing will help you when the entire trachea, which is very supple, collapses. and I won't talk about this, sorry. So extremely important to be ready. And remember, with these neck nodes, tracheostomy, cricothyrotomy, everything is challenging. So doing pre-op ultrasound, identifying the cricothyroid membrane is very important. And the rigid bronchoscope is the rescue airway of choice. So the rigid bronchoscope is something that you can use to kind of stent the trachea. The completely collapsed trachea can be stented. We have 1 or 2 cases presenting like this in a year, where you have complete loss of airway. And this rigid bronchoscope, it's like a metal tube in the endotracheal tube in the trachea, and it has a ventilating side port, so you can actually ventilate these patients, and this can really save your day if you have complete airway collapse. So avoid muscle relaxant in these patients. Combination of sevoflurane and inhalation agents, propofol, should be sufficient, but even with that you can lose the airway. Now tracheobalacia, extubating this patient, you have to be extremely careful. Communicate with your surgeon. Your surgeon will tell you that the tracheal rings are very soft, or he will tell you how it is. Or sometimes he might excise some rings and do some anastomosis. So before extubating, you can, do over a tube exchanger, you can do it, extubate the patient. And if your patient goes into stridor, re-intubate. Do not extubate immediately. Keep this tube for at least 48 hours in the recovery room, and this will kind of stent the trachea. And the logic is that, the fibrosis sets in, and this stabilizes the trachea. So after about 48 hours, keeping the patient on with the tube or on pressure support, the way to extubate them, and a good way to extubate them, is using a flexible bronchoscope. So what we do is we put the flexible bronchoscope inside, distal to the endotracheal tube, and you look at the tracheal rings, deflate the cuff of the endotracheal tube, and you start withdrawing the endotracheal tube along with the bronchoscope that is distal to the tip of the tube. So as you're withdrawing the endotracheal tube, you can visualize if there is any dynamic collapse. Remember, here the problem is dynamic airway collapse. So if there is dynamic airway collapse, you can just slide the tube back. You don't need to extubate this patient and re-intubate. So using a bronchoscope is much better in these patients where you're suspecting this, rather than using a airway exchange catheter. And of course, if you see this kind of dynamic airway collapse even after 48 hours, then it is better to do an elective tracheostomy in these patients. So sorry for the extra time that I've taken. I'd like to conclude by saying that in all these settings, I've told you the specific considerations, but what's paramount is the prior airway planning of the team. And this is crucial. In addition to routine airway assessment, remember in oncology, you need some additional assessment in these head and neck cancer patients. It's not important to just see thioventilation and mouth opening. You need to look at further things. And imaging can give you very, very important information, including the diagnostic procedures. And rescue airway does not follow the conventional algorithms, right? If you fail intubation, fail ventilation, you might put in a supraglottic airway. This patient has trismus, tongue lesion. You can't put in a supraglottic airway device. I fail ventilation with the intubation. I fail supraglottic airway device. Next, I have to do cricothyrotomy. This patient has big nodes. How am I going to do that cricothyrotomy? So conventional algorithms may not work, and you have to have a rescue plan. And you may often have to bypass some of the steps of the conventional algorithm for unanticipated difficult airway. And these are the things that you have to keep in mind, especially when you're anesthetizing head and neck cancer patient. Have a plan, have a backup plan, and I would say a plan for the failure of that backup plan as well. Thank you very much for your attention. Remember, good preparation does not always lead to success, but lack of preparation guarantees failure. Thank you very much for your attention. I'm sorry for the extra time that I have taken. I'm happy to take questions.
Thank you, Sheila. A great talk. I think when we hear from the authority of airway, there will not be any question for you. You have enlightened everything about the airway. If there are any question in chat box, please.
Yes, sir. There are few.
It cannot happen that there are no questions. That everything is understood, which is not possible, or nothing is understood. Sorry.
Hello, ma'am. Good morning.
Good morning.
Hello.
Yeah.
Yeah. If the patient is coming for a recurrent surgery who has received neck radiation, is it mandatory to check for thyroid profile?
Yes, usually the surgeons do it because post-RT, it does affect the thyroid function. So this is something that is often done, but yes, this is a good point. You could keep it in mind. But now with IMRT and all that, it doesn't really affect so much, but this is something, especially if you see clinically also, you might see, that might give you a cue. But by and large, the oncosurgeons, if they suspect this, they would do it. So it would already be there. Yeah. But you're absolutely right. History about this is, taking this history is important. But routinely for every post-radiation doing thyroid function may not be required.
Okay. Ma'am, you said that you use dexmedetomidine prior to awake nasotracheal intubation. So do you use only dexmed and spray as you go technique, or you use airway blocks and local anesthetic nebulization also?
Yeah. So this is a very good question. When I joined the institute, we used to give translaryngel, we used to give bilateral superior laryngeal nerve block and all kinds of things, along with a lot of sedation and a lot of things. Now we don't give any blocks. Okay. So if you look at the very nice guidelines, awake tracheal intubation guidelines, which have been published in BJA by the Difficult Airway Society, I would request you to read that. Very nicely done. But unfortunately, we don't have, remifentanil in India for some reason. I think we don't have it yet, right? But remifentanil is a very good drug if at all you use it, because it has a very short context-sensitive half-life, and it's a rapid switch on, I think 4 minutes or so. So it works really well and suppresses your airway reflexes. But we are very fortunate that we have dexmedetomidine, which is very expensive in the Western world, and it is very widely available, and anesthetists love it so much. I don't think there's any part of the body they've not put intrathecal, epidural, everywhere. So we should take advantage of this, because this is such a beautiful drug that you can use. And don't give a bolus. 1 mic per kg is what I give. So a 50 kg guy, 50 microgram, and give it over 10 minutes. So I give glycopyrrolate. Now glycopyrrolate we don't routinely use. But in cases, unless it's contraindicated, it's really useful, because blood and secretions are the enemy for fiber optic. Trust me, when you have, and it's a difficult fiber optic, you have a lot of secretions, it doesn't work well. So you have, give your glycopyrrolate, and you give dexmedetomidine infusion. And then you don't just push the fentanyl and midazolam early. You have to be really careful. As I mentioned, I always say, compromised airway and difficult airway are different. If you have a problem, you can lose the airway completely. You have to ask yourself the question, why am I doing this awake? I'm doing this awake because the airway is difficult. And here, if I lose the airway by giving sedation, so you have to be very careful. The other important thing, if you give me a minute, the important thing is, earlier we used to, people use a lot of sedation as a substitute for good counseling and good topical preparation. If you spend good time in counseling, and if you give good topical preparation, you don't need sedation. So I would say good counseling, good topical preparation, plus minus sedation. Some patients may need it. And then after doing this, what I do is we put Otrivin, we put nasal jelly. And, if the mouth opening is good, then I would even spray with the 10% lignocaine spray. And we give not tracheal, translaryngel, because we're going through the cricothyroid membrane. Now, even this is technically not necessary, but we make it routinely so that all our PGs and all our students learn how to do a laryngeal handshake. They, palpate the rhomboid structure, move it from side to side with the index finger. They palpate, they identify what is cricothyroid membrane, where is the tracheal, where is the thyroid cartilage. So, doing this routinely for awake tracheal intubation helps them in an emergency. And what you do is your 4% lignocaine, you can just, instill this through the cricothyroid membrane, and the patient will cough. The moment it goes in, the patient will cough, and the entire subglottic part gets anesthetized. Now, this is the only preparation that we do. No blocks. It's not required, because look at it. You're counseling the patient. You're giving him 3 injections. He's not going to be cooperative. So, in the Western world, they don't even do this translaryngel, but I find it works quite well. But in addition to this, I keep some additional 2 or 3 cc of 4% lignocaine. And while I'm doing the fiber optic, go up to the vocal cords, and, don't go through the vocal cords. See how the patient is behaving. If the patient is not coughing and bucking, the worst thing you could do if he's coughing is go through the cords. Then I would instill some local anesthetic, and I will spray as I go if I see that. Otherwise, I won't. So always keep it as a backup. Through the, working channel, you can infiltrate the drug. Some people put an epidural catheter and start an infusion. But, again, there are cost implications and whether you need to do it. So I do it more SOS. So if my topical preparation is not good, I just spray as I go. And once you've entered the cords, also, if you see the patient is again coughing, bucking, don't go further without spraying, because, obviously your translaryngel has not worked. So these are some, things I learned over time. And I think what is paramount is telling the patient that this is very important for you. People tell me that, no, we have to give GA because the patient doesn't want this. I said, have you explained why you are doing this? You have to tell them, look, We could lose your airway. You could lose your life during this procedure. We don't want to do this. This is very safe for you. Patient will agree to the technique. And counseling him, what is going to happen when this happens. You'll feel this discomfort. You won't have pain, but you'll feel something going through your nostril. All this is very important, because then the patient will become cooperative. I've rarely had to use fentanyl or anything else in a very uncooperative patient, but I think good counseling and good topical preparation really is the recipe, plus minus sedation in a few cases.
Thank you, ma'am. There's one question in chat box: how to manage tobacco or nicotine withdrawal in head and neck cancer patient in post-op period?
Yeah, this is a real challenge. So we do counsel them. There are counseling and session, these things to the preventive oncology team tries to counsel them, stop before surgery, because often, but that is often not very practical because the disease also is progressing. So at least 1 week before we try. But withdrawal is a problem, and you can see this happening. But fortunately for us as anesthetists, we don't see it much, because after we extubate this patient, these patients are not on a ventilator, they're not with us. But intraoperatively also you can see sometimes shoots in blood pressure, tachycardia, and sometimes you're wondering. And the other thing I missed telling you is many of these patients, they have a lot of pain and they're already on some fentanyl patch, they're already receiving high dose of morphine. So sometimes what analgesia you are giving is not adequate, because they are already receiving so much morphine. So that history is very important. What medications are they taking? Because these patients, you have to be careful, because the requirement is only so high. What you're giving might be a very low dose. So by and large, we don't face so much of that problem, though it is an issue, I agree, but I haven't really experienced it, maybe in 1 or 2 odd cases. And post-op, if we see this, then we use the nicotine patches. We start this on a suspicion also. But otherwise, I don't see it as, at least in my experience, I have not had so much of a problem with this withdrawal.
Thank you, ma'am. Go ahead with that.
There's one more question in the chat box. Dr. Veena has asked for experience with buprenorphine patches during head neck surgery.
Yeah, no, we don't use that.
Don't use it. Bivalve patch is not used. Okay, right.
Pain team usually they use fentanyl patches and PCAs and all, but not buprenorphine. I don't think they're using it. Not in head and neck case.
Okay. Yeah. Dr. Kapre, madam, has one question. Good clarity on extubation versus tracheostomy in the post-operative patients.
Right. Is that a question?
No. She has experience.
Okay. Thank you. Because we've really got a lot of recognition for this work that we did. Because to be honest, I felt Tata Memorial was in the right position to answer this question globally. Because I used to ask the surgeon, how are you deciding to do tracheostomy in this patient? Why do you want to extubate this patient? And they had no objective. They couldn't, some people used to extubate, some people used to do a tracheostomy, so it was based on their comfort level. There was no objective criteria that, okay, if this is there. By and large, there was some sort of this thing, but there wasn't something to guide a clinician that, okay, if this is there, it's unsafe to extubate. If this is there, of course, that's, and why should we leave it to the surgeons? As anesthesiologists, we should know which patients we can keep the tube in, so now with this criteria, we tell the surgeon, no, we'll keep the tube. We need not do a tracheostomy in this patient. They can keep a tube overnight, and that's so good for the patient also. So this is really, it was something that baffled me, and I felt I should study this, and have an answer for this. Thank you, madam.
Over to you, sir.
Hello.
As you said, it's very easy to move into the fiber optic intubation with topical
and this sedation or counseling. It is very easy to visualize through the fiber optic with topical and with counseling. But when we put the tube through the fiber optic, it is very difficult. There will be painful procedure at that time. And I think they need some block or something like that for putting the tube through the fiber optic. Over the fiber.
Actually, no. So that's what I used to think, because I used to give them superior love. I used to give everything. And, I think we just bombard the patient with a lot of lignocaine here. It's really not required. Though we use fiber optic, the passage of the tube is blind. Remember that the passage of the tube is never under vision, so it's not a completely visualized procedure. And often what happens is the tip of the tube, it impinges at the level of the arytenoids, and you might have to rotate it by 90 degrees, and this might help you pass the tube. One way to overcome this is, take a video laryngoscope if you have one, or even a direct laryngoscope, and not a full laryngoscopy, but you can just spray the tongue, and and that will help you pass the tube. But if you've sprayed the cord, sir, and you've given a good translaryngeal, the passage of the tube is not painful. It won't be painful. I don't think so. But really try to do this procedure without blocks. Spend a minute extra in counseling. It really helps. Even passage of the tube through the nostril, you tell the patient, you have patients who just jump up. They're not expecting what you're going to do. You're just saying, I'm doing intubation awake. But what is the actual, walk them through the entire procedure. That first I'm going to do this. Then I'm going to put this through the nostril. Then this will happen. Then, they are so well prepared. And when you tell them it's for their safety, they are willing to, they're very cooperative. So I find that, I don't know, these are just some practical things, not written in books, but it's really useful.
Madam, can I add something?
Yes, please.
While doing a fiber optic bronchoscopy, I think when you are sliding the tube, if you find it slightly difficult, not able to pass, ask the patient to take a deep breath. And while he's taking the deep breath, just push the tube in. That may perhaps solve most of the problems.
Right. Yeah. But I would recommend if you are having repeated problems, if you're rotating, it's not happening, better to do it under vision by putting a VL inside. Have a look, because sometimes, this can cause trauma, and you're not able to, and it can be quite frustrating experience because your bronchoscope is already inside. You're already,
madam.
And then, he's already having difficulty breathing. And then
टाटा में join करो જ્યારે બોમ્બે આવીશ ત્યારે મારો નંબર લઈ લે કે મને કોલ કરજો પછી મેડમ ને કોલ કરે તો કે મને જોઈન કરું છે ટાટા માં કેવું કરું તો કે આવી જા કે
I think someone
મને કીધું જ્યારે બી તને બોમ્બે માં કામ કરો મને ફોન કરજો ત્યારે આપણે કઈ આઈડિયા જ નહીં ને કઈ બી બોમ્બે નહીં કઈ સૌમાં પહેલા તો ટાટા માં જ એન્ટ્રી કરી હતી ને બોમ્બે માં હા સૌમાં પહેલા 6 મહિના ટાટા કર્યું તેના પછી
excuse me,
કામ કર્યા પછી કામ કરી લીધું પછી કીધું હવે તો કેટલા 18,000 રૂપિયા મળતા મને પછી મને તેના જે છોડ્યો હતા
please mute all.
Yeah.
મને કીધું સર હું બોર થઈ ગયો
Dr. Sheila, I have a question.
Yes, please.
Which type of tube are you using? RA tube or armor tube?
We use both. To be honest, I like Portex tubes. Okay.
Yeah.
Also, like I told you, when I use this, I always look at the CT scan. Okay, because we've really burnt our fingers with cuffs getting punctured. So I look at the scan. I look for nasal spurs. And you're not doing a scan to look for this. The scan is already there. Look at the scan or speak to the surgeon. The moment I see the spur is on that side, and I didn't know spurs are so common. I didn't know this. When it's quite frequent to have a nasal spur. I was not aware of this. So I avoid that nostril and clinically check. And the advantage of this is, it's transparent. The suctioning is very easy post-op.
Yeah.
And when we use the other North Pole tubes, what we do is we use them, but we cut them. Yeah. After the surgery, we cut them. So otherwise, the suctioning becomes very difficult with that this thing. So make sure you cut it so that the suctioning can be facilitated. And when you're doing awake fiber optic intubation with that RA tube, it's much easier with the Portex tube. If you're using it with the RA tube, you have to straighten that tube. So you need an assistant who will completely straighten the tube, which is threaded over the bronchoscope. So it needs a little training, but you can use it. But definitely, it's atraumatic, it's softer, this thing. But you must put loads of lubricant and jelly, and don't use a very big size tube. And use the more patent nostril. So I would say 90% of our cases are still done using a Portex tube. So it's not
RA is expensive.
RA, of course, you can use, but this is my practice. Yeah.
Okay. Thank you.
Are there any more questions?
Thank you very much, Sheila Madam. That was very interesting and informative indeed. And as anesthetists, we are considered airway experts. So people will have a lot of questions for you every time. Thank you for your time.
Thank you.
So with that, we move on to our panel discussion. Perioperative management, my way. And the moderators are Dr. Vivek Bhargav and Dr. C.S. Cham.
Dr. Sheila Myatra Madam and Dr. Dipika Madam is on board right now. So Dr. Himanshu, you can.
Dr. Dipika, are you online?
Yeah, she's online. Madam is online.
Madam, there's a question for you. What do you think about the intraoperative fluid management? Is it liberal or restricted?
Right. So this is a very important question. Like I mentioned in my head and neck talk, these patients are very hypovolemic to start with. These patients. So you have to be, even head and neck patients. So you have to be really careful. Now, again, it depends on the duration of surgery, and the duration of surgery for these commando surgeries, and if it's a flap surgery, free radial, free fibula, these are whole day surgeries. So you have papers with liberal fluid management, you have papers with restrictive fluid management. I think it's an approach in between. I think you have to individualize for each patient. And definitely in these surgeries which take long duration, especially the microvascular surgery, I would say that you should have an arterial line in. And you can use your pulse pressure variation, which is a very good dynamic parameters. You don't need a CVP or central line or anything like that, because it will not help you assess fluid responsiveness. So what you don't want to give too much fluid also to this patient, and you don't want to give too less. So you can look at the pulse pressure variation and any monitor that can give you invasive arterial pressure. It's a simple software which you can upload. I myself was not aware of this, but you can get pulse pressure variation very easily on Edwards monitor, on Philips monitor, on any of these monitors you can get it. And you can look at that, and you can, and you know, it works very well in patients who are when you're giving we use it in ICU, but it works better in the operating room because you're paralyzed the patient. All patients are paralyzed. So we keep a target less than 12 pulse pressure variation at all times. We keep it less than 12. And of course, we go by other clinical criteria. You're seeing tachycardia, you're seeing that, you have to maintain adequate depth. You look at the urine output. We do a blood gas because you already have an arterial line in. Look at the lactates. We keep the lactates under 2, look at for whether there's any acidosis, but don't underestimate these patients and, their management, because we have a lot of data now. We have publications that their recovery is better and more superior if you do good fluid management. So just restricting or giving too much, it cannot be a one size fits all. It has to be individualized to the needs and situation of that patient. And that is why I would say that when you have long duration surgeries, you should use dynamic parameters to assess fluid responsiveness, which can help you. Now, in some centers, they're also using like flow track, they're using stroke volume variation. So stroke volume variation, pulse pressure, if you don't have that monitor, then pulse pressure variation is very, very, very cheap, easy parameter that you can use, very underutilized in India, but we can definitely help you guide your fluid management.
While dissection, you have to control hypotension to prevent the blood loss. And yes, after dissection, when surgeons are doing microvascular free flap, then you can make patient normothermic or little bit higher.
Yeah.
Volume. Yeah.
Hello.
Yeah.
Dipika madam. Dipika madam, are you able to hear me?
Yes, yes.
Madam, what is the take on the urine output for long procedures like microvascular flaps, which are lasting for long duration, 12 hours, 10 hours?
Yeah, I mentioned in my lecture that you have to keep, intraoperative and postoperative both 1 to 2 ml per kg per hour. You have to maintain the urine output because you are keeping the patient a little bit higher level of fluid level. So yeah, and the urine output should be not 1.5, but it is around 1 ml per kg per hour.
Madam, we have a very peculiar observation. till the time primary is resected, urine output is very little. Once the primary is resected, probably the urine output increases. I don't know why. Can you?
Because by dissection, we are keeping the patient on the lower side. Blood pressure, we are keeping on the lower side. So,
no, even with blood pressure, sometimes the output is on the lower side.
Mm-hmm.
Hello.
Hello.
Madam, even with good blood pressures, the output is still on the lower side.
So, which type of anesthesia we are using? If we are using the inhalation agents, which type of inhalation is using? We are using
either isoflurane or sevoflurane.
Okay.
I am specifically talking about head neck surgeries.
What happened?
The output is slightly on the lower side.
Maybe it depends on the patient, individual patients, but yeah, there is no reason to maintain a low urine output. If you are keeping the hypotension, that obviously it will be low urine output.
Hello.
There is no other reason if your patient is absolutely normal.
If I may add a comment to this.
Yes.
Yeah, sure.
Again, like Madam has rightly said, it depends on the anesthetic that is used, the individual circumstance. But again, it depends on the volume status and the perfusion. So blood pressure, what we are looking at is not a very good, reflection of the of the perfusion. So you may have a normal blood pressure, but if you do the blood gas of this patient, the lactate may be 6. So I'm just trying to say that it depends on the situation, what is the volume status, how much fluid has been given until the resection. There are many factors involved. We can't just point out that this may be the reason.
Most of the time we see response during primary resection of tumor.
Sorry. Hello, Dr. Sheila, ma'am.
Yeah.
Yeah. So many times we see stress response during primary resection of oral cancer tumors. So can we add few nerve blocks to reduce this stress response or to reduce the requirement of IV drugs?
So I really don't, I know some people are very, very fond of these nerve blocks, but I wouldn't really advocate it. It's not really advocated in clinical practice. So you have so many other ways, so many drugs that you can use to attenuate this response transiently. So you need not give blocks for that. I would not, it's not my practice and it's not advocated either.
Say in head and neck cancer, it is not comfortable to give blocks to the patient.
And also understand, these blocks are not so easy in cancer patients. You have post-radiation neck, you have fibrosis, you have, the normal anatomy itself it's not so easy as people say, in non-cancer pain. So giving this, I mean, I don't practice it and we don't do it at Tata Memorial Hospital for this purpose, but it's not advocated either.
And ma'am, use of ultrasound for airway assessment, like how it is useful.
Right. Yeah. So role of
what parameters you need to see.
So is Dr. Vijaya Patil on board, because she's an expert at ultrasound, so maybe she can take this question. But where I would use it is Vijaya madam there?
Madam is there.
Yeah, so she's an ultrasound expert, so she can take this.
So can you hear me?
Yeah, we all can.
Yeah. So basically for ultrasound, if you look at it, there are no specific parameters which can tell you whether the airway is difficult or no. Lots of people have tried lots of measurements, like the volume of the tongue, or looking at the distance between the skin and thyroid, but it is really not good. It can tell you the pathologies, like it can tell you about epiglottitis. So when you say thickness of the epiglottis is high, it tells you that it's a difficult airway. But the rest of the parameters are really not well validated. So what we use the ultrasound mainly for, if you have got a very bad neck where you cannot palpate and you want to look for the cricothyroid membrane, it's a very good measurement. So even if you have got lots of lymph nodes across, like I don't know how many of you practice the cancer and head and neck cancer, but you will get many times patient coming in stridor, patient need emergency tracheostomy, or patient coming for airway management who have got the neck which is bad and anteriorly either it is scarred and you can't find anything. So in those times, your ultrasound is extremely useful. It can tell you where the trachea lies. It can tell you the distance between the skin and the trachea. And that way you can guide the surgeon where he can puncture. So that way we have done 3 or 4 tracheostomies in extremely difficult scenarios. You can use it for giving the blocks. You can use it for giving your supralaryngeal nerve block, or you can even use it for giving your, when the trachea palpation is difficult, to give the intratracheal block. But that is what the main role of your airway ultrasound in the airway management in difficult airways. Rest of the things, if you go into the literature on Google, you will find people have tried, but really there is no evidence to suggest that a particular parameter is useful to looking at the predicting the difficult airway.
Yeah, absolutely. I'd just like to add that not only in the emergent situation, but I would recommend this even in the elective situation. When you're anticipating a difficult airway and you think that this might fail or you may have a problem, it's a good practice, especially when you have a difficult leg, like Madam has said, to identify and mark it also. So that in case you have a problem, you have a backup plan.
Next question. Hello. Next question is to Vijay, madam. Madam, cancer being a prothrombotic state. Hello.
Yeah.
Cancer being a prothrombotic condition, what is your strategy for perioperative coagulation for long onco-surgeries? Not the short ones like CA breast, not the short surgeries, but for long surgeries.
Hello.
Hello.
Yeah, can you hear me?
Yeah,
yes.
Okay. See, the cause for the cancer prothrombotic state is very different, and not necessarily every time you'll be able to pick it up on your coagulation screen, unless you are doing the TEG. So the thing is that if you look at in general guidelines also, there is no guideline which says that you should be looking at the coagulation parameters in cancer just because they have got cancer. We do not screen patients for coagulation parameter, none of these, not even the major surgeries, unless like they're the liver surgeries, hepatobiliary surgeries, or major thoracic surgeries. There we ask for. Otherwise, we do not ask for the coagulation parameters, and it's not necessary. So generally, these patients, because of the other conditions, that they are prone for getting DVTs and all, so that's why you should be giving them the DVT prophylaxis. But measuring the coagulation, doing the coagulation studies, it's not recommended. It's really not useful also.
Thank you, ma'am.
Dr. Vijaya, ma'am.
Yeah.
Yeah, ma'am, do you use albumin intraoperatively for abdominal cancer surgeries per se, cytoreductive surgeries? Do you use albumin IV intraoperatively?
No. So again, in this case, you may consider I'm little rather prejudiced. I would say I'm little against albumin use routinely. So I do not use albumin for any reason, neither in OT nor in ICU. So if you understand the role of albumin, basically everyone wants to use it. Okay, it's a colloid, it will stay in circulation, give you good volume expansion, and the patients will be okay. But we have to understand that when you will give fluid only to the patients who are hypovolemic, or rather you will say that patients are fluid responsive. So in those patients where there is hypovolemia per se, obviously there is a low hydrostatic pressure, and whatever fluid you give will be maintained in the circulation, because the factors that push your fluid out is mainly hydrostatic pressure of intravascularly and your oncotic pressure outside the vessel. So generally, if you have got low, unless you cause overzealous fluid resuscitation, which will increase your intravascular hydrostatic pressure, the fluid that you give in face of hypovolemia, again I'm very clear, in face of hypovolemia, will stay in the circulation and you do not need any colloid. Now the only problem occurs that suppose if you are doing a major surgery, where you expect that there will be, after some tissue dissection, it will release inflammatory markers. And these inflammatory markers can give rise to your so-called SIRS, which will increase your capillary permeability. Now here the question comes is, how much capillary permeability is increased? You and me can never know. So if you think that the patient has got increased capillary permeability, which intra-op generally you will get to know where patient's temperature starts rising, patient is becoming tachycardic, okay, showing the swings in the arterial line trace, or if you are using your PPV, then you'll see PPV increasing. So you understand that, okay, the patient is hypovolemic, requires fluid, but the increase in temperature and probably tachycardia, in spite of giving good analgesia, in your opinion, you feel that this patient may be going in SIRS, which is very common in patients where you are doing abdominal cytoreductive surgeries or massive tissue dissections. Now, in this case, okay, my crystalloid probably may slip out, but that your albumin or colloid that you are using will stay inside, because you really don't know how much is the pore size. So what I do generally again is, you give, if you give the crystalloid to the patient, how do I know that my fluid is seeping out? Is if I give, suppose my patient is hypovolemic and I give X amount of crystalloid, say, which has taken care of hypovolemia, I expect that the effect of that hypovolemia come in terms of maintaining the blood pressure, decreasing the tachycardia, should remain sustained if there is no further loss. If I give the fluid, I get the response, my tachycardia settles, my blood pressure comes up. But within 10-15 minutes, half an hour, that effect goes away. My patient again starts showing the signs of hypovolemia, tells me that probably my fluid is going out, and in face of no external loss that you are seeing, it's probably going out in the interstitial fluid. In these cases, you can use albumin, 4% isotonic albumin, and then you see the albumin is giving you the response. But again, what you have to see is whether that response is sustained. So if I get a sustained response of 2 hours or 3 hours, okay, that tells me that yes, my albumin is staying in, but my crystalloid is getting lost, then I will use albumin. Now in intraoperative stage, it becomes a little difficult to judge because there will be ongoing losses, there will be ongoing problem. So my strategy will be, first I use crystalloids only. But the moment I start seeing that, okay, patient is requiring lots of crystalloid, there is not much blood loss, or if your intestines are looking a little edematous, where your surgeons will tell that intestines are looking edematous, in those cases only then I'll go for albumin, but not by design.
Okay, thank you, ma'am, for that. And regarding blood transfusion also, I wanted to ask you that is there any data which suggests any long-term sequelae of blood transfusion leading to any malignancy or recurrence? And should we restrict use or should we go liberal on blood transfusions?
So this question is to me or Sheila?
Yeah, you, ma'am, Dr. Vijaya.
Okay. So if you look again at the evidence of effect of blood transfusion on recurrence or distant metastasis, it's mainly in the patients with colorectal. So in the colorectal surgeries, there is level 1 evidence that the blood transfusion does increase the rate of local recurrence and distant metastasis. Rest of the malignancies, there are not those big studies or there is no that robust evidence. But in colorectal, yes, there is a robust evidence. And if we apply these results into other onco cases, then that's what we generally do. So we're applying that. But if you ask me the evidence-wise, it's colorectal.
I just want to add one thing about the transfusion triggers that people are maintaining. Remember one thing, that when you're looking at a transfusion trigger and you're keeping your trigger as say 7, these are in stable patients. This is not an ongoing bleeding. A lot of people will do the intraop hemoglobin and an ongoing bleeding patient and 7, and then they're happy to keep it. And the next hemoglobin you're checking is 4. And it's not the value of hemoglobin alone, but you need to look at tissue oxygenation parameters. Okay, your hemoglobin may be 8 or 9. Patient is very tachycardic. Patient's lactates are 6. Patient is, acidotic. This is the patient I would consider volume resuscitating and even giving blood, because it's not just the the delivery; it's also the content. So you have to individualize it. It cannot just be that, oh, my target is 7 or my target. It also should take into account your tissue oxygenation parameters.
Yeah, I completely agree with Sheila. Like, if you are taking a patient who has got, say, is coming for the emergency, like, cancer, many times you get these semi-elective cases where the patient has got big tumor, the patient is showing the signs of sepsis or SARS, but unless and until you take out that tumor, you cannot go ahead. So these type of patients, again, when they are coming for the surgery, probably you'll have to maintain the high transfusion threshold. So what I feel is when you're taking a case for surgery, you have to have looking at the underlying medical conditions, you have to decide what's going to be my transfusion threshold. So not for every patient we keep 7 or 8. Sometimes we keep even 10. And the ongoing blood loss, as Sheila very correctly said, you have to maintain your transfusion threshold as 9 or 10 so that you have got a safety margin that if the suddenly patient, and of course it depends on how reliable blood bank you have. Like for our blood bank is pretty reliable. We also have got this massive transfusion protocol set in for the major blood losses expected, or even for that matter, unexpected blood losses. We immediately contact the blood bank and tell that this scenario is evolving into massive blood loss. Please send your 1 person. So there's 1 person coming from blood bank who is actually seeing the situation and liaising with blood bank and giving us the blood. So if you have got that much of a good support, maybe you can keep your transfusion threshold of 8 or 9. But if you have got a support where your blood bank lies outside, it will take half an hour or 1 hour for you to get blood, then I would say that you keep the transfusion threshold of 11 or 12 also. There is no harm in it, because ultimately what's important is patient should not die of massive blood loss and anemia. So in those cases, ultimately weighing the risk and benefits, it depends on what scenario or what backup you have got.
Okay, thank you, ma'am. One last question for Dr. Sheila, ma'am. That if patient is coming up with vertebral mets, say suppose a patient of CA prostate with vertebral mets, is it advisable to still go ahead with the regional anesthesia at the spine in form of spinal or epidural, or is there any absolute contraindication?
expert at regional, but it's not an absolute contraindication. I mean, you can, again, it depends on what is the surgery that the patient is undergoing, but you can definitely use a space, another space if it is feasible. And again, it depends on your expertise and your comfort level. It cannot be that, yes, for this you can do and for this you cannot. So we have done it in patients with METs as well, just using another space. So that is possible. It depends on your comfort level. Yeah.
If I may add one more point,
Yes, ma'am.
It's better that you have got a proper MRI spine done, which will tell you, because many times in X-ray you will see or CT you'll see a big met, but there may be other metastases in other vertebrae which may not be picked up.
Yeah,
so it's better you know which vertebral level you are going to go and confirm with your orthopedician. And the second thing is, in these cases, again, as Sheila said, there is no problem from medical point, but from medical legal afterwards, your patient should not blame you. So you better explain to the patient that this is the reason, these are the advantages of giving spinal, and that's why I'm proceeding. And remember, if in soon, because these are the patients who are on sort of advanced malignancies, so soon they are going to develop some neurological problems. So they should understand, and they should say, yes, I understand that this problem will go, but it will not be related to your spinal or epidural, and then you can proceed.
Also,
otherwise
if the patient is, you feel is really going to benefit from that regional procedure. If you
Yeah.
are in doubt, if you have any doubt, and if J is not contraindicated, then better to be safe and go ahead with general anesthesia. I mean, you don't have to be very heroic and say that, no, I will do this. So I think it has to be a, way taking into consideration a lot of things. And like Madam has said, definitely you have to be sure about where the met is and when your imaging was done and what is the current setting before you approach another space.
One question, madam. We are in an era of ultrasound. Is there any role of ultrasound? Hello. Hello.
Yeah.
Can you hear me? Yeah, we are in an era of ultrasound. Is there any role of ultrasound in fluid management, intra-fluid management?
You want to take that, Madam?
No, yeah. I don't see. There's a role of ultrasound in the intraoperatively. It depends. Like, the thing is that it depends on what surgery you are doing. So ultrasound can only tell you if you're looking at IVC, and if you see the eye. So if your patient obviously is going to be on controlled ventilation, what you are looking at the IVC distensibility index. So only if you can see the IVC, then you can say okay. And that again, it doesn't tell you with 100% sensitivity the patient is fluid responsive, but it can definitely tell you whether the patient is fluid tolerable or no. So if you have got access to it, you can look at IVC and say, but again, it's one thing is that it's a very subjective measurement. You should know that where you are looking at IVC, you have to cut the IVC exactly in the center. If you get a tangential cut of IVC, it's of no use. So I really don't think that intra there is role of ultrasound. I'll rather go for my arterial line with, if I have got a good monitor, I'll look at PPV, or I can have arterial line and central line, but both transduced, and then looking at fluid challenge sort of a thing. But ultrasound per se,
I'd just like to add that those people who have transesophageal echocardiography, the surgeries where you really have to worry about the fluid are coelomic surgeries. And in coelomic surgeries, both thoracic and abdominal, because of the incision and this thing, you won't be able to use transthoracic echocardiography and look at the IVC variability. So if you have TE and you have expertise doing, a lot of people are doing it for GI surgeries, then you can look at SVC variability. And if the variability is more than 30%, this patient is likely to be fluid responsive. But very few people have the probe or have the expertise to do it. So it's better, like Madam said, to use other parameter.
Yeah, or Doppler, the esophageal Doppler that you can look at if you have got it again. So that will tell you, but not.
Transesophageal Doppler, actually, I would say is not very good in intensive care unit, but works very well in the operating room. A lot of studies with transesophageal Doppler.
Yeah.
It's like a Riles tube. So it's very easy to insert. And unlike transesophageal echocardiography, which is not continuous, this is continuous. So you can have the values, and the only thing is you have to get a good Doppler signal. So once you have a good Doppler signal and your probe is at the right place, it's like a Riles tube only. And then you can just, get a real-time tracking of the cardiac output. And you get a parameter called the corrected flow time, which you can look at. And this is the parameter to assess fluid responsive. So I definitely, transesophageal Doppler is something that you can use for major GI surgeries.
Dr. Vijaya ma'am.
Yeah.
Yeah, you talked about use of 2D echo in pre-op screening in patients receiving anthracycline group of drugs. So only plain 2D echo, is it sufficient, or we need to do a stress echo, double stress echo?
No. Generally, anthracycline give rise to cardiomyopathy, not the coronary artery disease per se. So that is the reason your plain 2D echo is good enough. But because of I was given only 20 minutes, I didn't go into the detail. But again, whether you really need 2D echo, or are you going to postpone the patient because there is no 2D echo? What we have done is we have had 2 years retrospective study where we looked at around 800 patients with CA breast, where these patients had received neoadjuvant chemotherapy, which they generally receive 3 to 4 cycles before the surgery to downgrade the size of tumor. And in those cases, we saw that our dose, median dose was less than around doxorubicin around 240 to 260 milligrams, and epirubicin was 360 milligrams. And in this, our incidence of cardiomyopathy, where we looked at ejection fraction drop less than 10%, was 1.3%. And in that, again, 0.5% patients were actually symptomatic, non-symptomatic. 0.8% were symptomatic, that there was decreased effort tolerance compared to pre-chemo. So in my opinion, you can just do plain 2D echo, or if your dose is less of the adriamycin, so always go through how much dose they have received, the cumulative dose. Then in those cases, the incidence of cardiomyopathy is 0.8%. So you really don't have to you can take your call. So I'm not going to say don't, because generally advisory says that patient who have received anthracycline based, you should do chemo. But this is our in general experience is that if your dose is less, your incidence of cardiomyopathy is much less. But the plain 2D echo is good enough, not the stress test.
Thank you, ma'am. Thank
you. Sheila.
Thank you very much, our moderators and the speakers for today's CME. They say Sunday is a day to relax, refuel, re-energize. I thank personally on behalf of ISNCB for taking your time out and attending this CME. And I formally now invite our Honorable Secretary, Dr. Sarita Zobrekar, to propose a vote of thanks.
Thank you, Dr. Sheetal. On behalf of ISNCB, I would like to convey my sincere thanks to the GC member MSc ISA, Dr. Saurabh Bade and Dr. Sheetal Dalal for attending today's program. Fantastic faculties for today's program. Dr. Vijaya Patil, madam, having so much of difficulty with her network connections, has connected very well to us after her lecture for panel discussion. There were so many queries and questions for her that were remaining. Dr. Dipika Patel, madam, has elaborated on a free flaps in a very concise and a very protocolized manner. My sincere thanks to Dipika, madam. Dr. Sushma Bhatnagar, madam, also in her busy schedule, had taken a time and have given a very good lecture on the opioid management and used in cancer care pain. And again, Dr. Sheila has joined out from the meeting and taken a time and have elaborated on her lecture on a difficult airway in head neck surgeries, and her taking up so many questions on the panel discussion. So I personally thank, and on behalf of ISNCB, thank you all the faculties for today's program. Today's chairperson for the program, Dr. Bhargava sir and Dr. C.S. Sham, heartfelt thanks from the ISNCB. A lot of thanks to our program head for today, Dr. Himanshu Marathe. Then Master of Ceremony of today's function, Dr. Sheetal Samay, all the senior members from ISNCB who have joined for today's program, and a special thanks to Mr. Nishant Bade from Atlantic and Mr. Manoj Singhi from Singhi Screen for joining today's program. There is so many questions and so many elaborative talks just remaining. This is only a part of Onco-Anaesthesia probably we could cover. So hopefully we will meet soon for taking another part of the Onco-Anaesthesia in the near future. So I thank you all and take your permission to wind up the session for today. Thank you.
Thank you very much.
Thank you.
Thank you and good day to everyone.
Thank you.
Thank you very much.